Right, welcome everyone. I see some excited faces in the room. I see some slightly nervous faces in the room. But welcome to our annual MPhil presentation block. It's quite amazing. I love seeing the process of from the very beginning 3 weeks ago till now. But many of you know that CPMH is a joint initiative between Stellenbosch University and us here in psychiatry at UCT. And you know that Brahma is our co-director. So I'm going to hand quickly over to Brahma to say a few words before we get into the nitty-gritty of what's going to happen today.
Hi, good morning everyone. Good morning, colleagues and students. It is just wonderful to see you at this point. Remember, this is a productive, constructive process where we hope to support you in developing what will be wonderful projects like the titles that I've seen. So all the best for today, and yeah, looking forward to seeing many of you at the end line very soon. So yeah, thanks guys.
Yeah, I just remember it's not about criticism. This is about academic debates and discussion and really bringing in sort of global mental health voices. What's really nice about this meeting or this presentation is that we have so many other people in the room that will comment, give suggestions, and because you're really early on in your proposal, you have the opportunity to make those changes, to integrate them in, to discuss with your supervisors. So nothing ever is set in stone at this stage. Yeah. All right. So just the way the logistics is going to work, as many of you know, we're very obsessed with time. I'm very obsessed with time, and Miriam is our timekeeper, so do keep an eye out for her. And really, keeping time is not only about it; it's an academic skill to keep time, but it's also about respecting the other people around you, so you don't take out their time. So it's a good skill to have. So we start you very early in the MPhil. Each student or each fellow will have 10 minutes to present. Then there'll be 5 minutes for the reviewer to give some comments. Student can then respond again, and then we'll open to the floor for more comments. Does that sound good to everyone? We're all comfortable with that. For those of you online, you can put comments in the text, and Claire and I will be on it on the side, so please do feel free to do that. And we were going to get started right away. We do struggle with time, and I'm going to hand over to Noma, who is our chair for the first.
Oh. A very good morning to you all. My name is Noma Moshani, a PhD fellow here at the center. As Kate said, that I was the program director for the first part. So our first speaker is going to be Sylvester Kayimba. As it was indicated that he will have 10 minutes, and his supervisor is Associate Professor Van der Stephen. Thank you.
Thank you. What a moment. Being a first presenter in the morning mind, but it's also good because you catch a very fresh mind to update the database. Indeed, my name is Sylvester Kaimba. I'm from Malawi. I'll take you through a proposed research topic. Yeah, I'll take you through the proposed research topic that I'm looking at the prevalence of and the psychosocial factors associated with suicidal ideation among college students engaging in online sports betting and gambling in Malawi. Yeah, we have to understand what is gambling or betting. So this involves playing games for money or other stakes, resulting to either you win or you lose. But gambling and online sports betting are increasing among college students through the policy changes, technology advancement, and as well as globalization. Let's now understand the global trends. A survey in 2025 in the US shows that 57.9% of young adults are engaged in the sports betting, aged between 18 and 22. However, 32.7% prefer online sports betting. Another study in Europe, in Greece, this was a study of many countries, Greece and Moldova, they shows that 22.6% of 16-year-old gamble past years, and 16.2% prefer also online gambling. Others, they prefer offline gambling and being preferred lotteries, casinos and other platforms of gambling. Let's now understand in Africa now. This is the prevalence of sport betting and gambling, but this was not one of the prevalence that you can compare and contrast, because this was taken in a different time zone periods. At the same time, it was taken in the different type of definition of gambling. But what it shows here is that there are really increased in terms of number of prevalence of students engaging in the online sport betting and gambling. Some define gambling as involving per month, some per week, some over lifetime. So that's why we cannot compare these statistics. Some Sub-Saharan Africa studies showing there's some sort of association between depression, anxiety, and sport betting and gambling. That was in Nigeria, and it shows 35% strong students in university strongly agree that indeed depression and anxiety associated with sports betting and gambling. Similarly, the same study shows that some sort of association between social isolation and interpersonal relationship challenges. But a study in Kenya also shows that there's a strong relationship in poor concentration in class and peer performance, even the dropout. So what are we talking about? There are limited empirical evidence, especially on the mental health, particularly on the suicidal ideation and associated factors in Africa, particularly in Malawi. Therefore, we need data to inform and contextualize specific intervention strategies. Now, what are we doing? So we aim to investigate the prevalence of and identify psychosocial factors associated with suicidal thoughts, depression and anxiety among college students in Malawi who normally engage in the online sports betting and gambling. Specifically, we want to determine the prevalence of suicidal addiction among college students in Blantyre who engage in online betting. And again, we want to examine the association between psychosocial factors and suicidal addiction among college students. Lastly, we want to also ascertain association between psychosocial and psychosocial factors with depression and anxiety among college students. How are we going to be done this study? This will be cross-sectional quantitative study. That will report according to ASTRO reporting guidelines. The study will be done at the university, Malawi University of Business, Applied Sciences, which is located in the southern part of Malawi. As of 2026, population of the university was 11,000, and they have 17 departments embedded in 5 schools. And one of the schools is Faculty of Engineering, which is the largest faculty at the university. Who are our participants? Sample size will be calculated according to population, according to population of the university, as well as the studies that I would have shown. We enroll female and male participants who are 18 to 25 years, registered under the Faculty of Engineering. Why? Someone might ask, why Faculty of Engineering? I said this is the largest faculty at the university. And also those engaged in online sport betting and gambling. So we have defined that one in the sense that those involving in the gambling 4 times a month, and they're putting a stake of money of $5 within a period of 3 months. Those will be categorized that are engaging in the sports betting. But we exclude the students that are long leave and absent during the screening period. However, a convenient sampling approach will be used to identify these participants. Let me take you through the procedure. The first and foremost is ethical approval. This is a good standard whereby we seek the approval from the UCT and the National Ethical Committee that will approve our study. Soon after the approval, we engage the university through emailing them so that we can book the appointment. At the same time, we briefly explain the study to the management. Soon they have granted their permission, then we'll have an appointment whereby we'll discuss the best approach of how we're going to identify the students. Normally we are thinking that maybe at the end of the semester, because they are meeting when they're opening, that would be opportunity for us to go and do our sensitization and the awareness. During the sensitization awareness, we use the posters, flyers, engaging the students face to face. Soon after, some people, if they agree to be involved in the study, then we'll do a screening process whereby a QR code will be sent through email to the Department of Information Technology. Some will be scanned through the posters. Even some will be sent the link so that the screening process will be done. That will be done maybe through the 1 week process, whereby we identify those engaging in gambling and not those engaging in gambling. For those engaging in gambling, we proceed for consenting. While those not engaging in gambling, we thank them for the time involving in the screening process. Online consenting will be done to the participant, identifying involving the gambling. After the consenting is done, we proceed with questionnaire administration, which also done through the QR code administration and link through the email and the scan flyers. However, this is a psychological study whereby some of who might have some sort of risk and discomfort in the psychology mind. So psychosocial support will be done by developing a helpline, a referral pathway, so that this can be helped right away. Then lastly, participants will be appreciated for the time to participate in the study, as well as the time to participate in the study will be appreciated. However, data collection will be done, psychosocial demographic data will be done, and academic will be done. Some tools will be used. Online gambling symptoms assessment scale will be used. PHQ-9 will be used, as well as some protective factors also some tools will be used. For example, assist and behavioral social support. Data analysis now. So this SPSS version 31.0 will be used, whereby the discrete data will be generated in the figures and frequency. The model regression analysis will be done. The first regression model will be done for the suicidal ideation as dependent variable. And then again, linear regression for depression and anxiety will be done. Ethical consideration, which is a big part in this study. Approval will be done. The consent will be voluntarily done, but they also have a right to withdraw at any time. Privacy is of paramount and confidentiality, whereby editable data will be used and stored in the server. What are the risks? The risks are there because people potentially they might have a psychological discomfort, and helpline will be done. Finally, there are benefits because the benefit will generate data that will eventually will help us to generate interventions and prevent preventive strategies. At this point, let me thank you.
Okay, all right. Thank you so much. We are now going to hand over to the reviewer, who is the Associate Professor Kani. Over to you.
Thank you so much. I see my video has been turned off. Is that fine?
Or maybe it might be problematic for the other people who are online.
Okay.
Are you not able to turn it on, or it's from our side?
It's from your side. It says the host has switched off my video.
For the benefit of the people online, otherwise for us, all we need is your.
No problem. Okay, so let me just start off by saying well done, Sylvester. I think that was a very clear presentation. I loved your slides, and as you said, it's not always easy to be the first student to present. And also just a thank you, because I think a number of the questions or the areas that I wanted to know more about, you've actually now presented this morning. So maybe just a reminder to make sure as you develop your protocol, just to be clear and to include some of those issues as well. So I know I only have 5 minutes, so it's not only the students that have to stick to time, but also the reviewers. So I'll try and be as succinct as possible. So just a few considerations really. Well, I think I can switch my video on. There we go. So just a few considerations from me, and I will send detailed feedback as well in an email. I felt it was quite important up front in your protocol just to define exactly what you mean by young people and really a rationale for this age group. A lot of your studies looked like they were addressing sort of the late adolescence and emerging adulthood. So 18 to 24, but I know your sample is looking at 18 to 25, so maybe just really make that crystal clear. You've also presented, I know this is quite a new and emerging area of literature, but if you could have a look and see if there are any studies, any systematic reviews, perhaps literature reviews that just give us a good global prevalence of online gambling. Even if most of this does come from high income countries, I just think that would be a really nice start and a really nice summary to your protocol. I think mental health conditions were well defined for me within your protocol, so well done on that. But I think what I was struggling a little bit with was just if you could outline what you really mean by these psychosocial conditions within your protocol. And I absolutely agree with what you've said in your protocol. There is definitely limited evidence on this topic in Malawi. But I do think there are some studies that do exist. So while these might be small qualitative studies, and albeit studies that may have some methodological concerns, I do think it's important to mention those. And then you can really show where the gaps are in the literature. I think that would be important. What you've done really nicely in your presentation is explain why you've chosen the engineering department. I think that's clear. Just make sure that translates into your protocol as well as your data collection. So I had some questions about, which online platform would you be using to collect this data, etc. But I think you've explained that. So as long as that pulls through into your protocol as you develop it. It was a little bit unclear for me within the protocol if your primary outcome was suicidal ideation. And I think you've spoken about, other common mental health conditions in this presentation. But I think it's something maybe just to think about, in your logistic regression, because I do think, you will have a lower number, well, I'm hypothesizing a lower number of participants who will present with suicidal ideation, especially if it's an online data collection. So maybe just think about that, or if you would want to include your common mental health conditions in your logistic regression. So that was just something maybe for you to discuss with your supervisor. And then also just making it clear how you would actually determine suicidal ideation, and if you would be measuring or looking at intent as well. And then I think you've mentioned it as well very nicely in your presentation, but one of the things that stood out for me is if you are specifically looking for suicidal ideation that has obviously ethical concerns, and you want to be really, really sure and critically think about, your distressed respondent protocol. And I'm sure this is something that you will start working on going forward, but especially when you submit to ethics, that is really going to be a critical part. And then I think just something in your benefits. I think another benefit really is that this will add to the literature on the prevalence of online gambling in low to middle income countries. And I think you should highlight that at the end because it would really tie everything together very nicely. You mentioned it in your aims about adding to the prevalence data. So just adding that to the benefits as well.
We are almost running out of time.
I'm done. That's it. So thank you for the opportunity to review this, and you'll get full comments from me.
Cool. All right, we're gonna hand over back to our speaker for some compliments. suggestions and maybe some questions. Online gambling is definitely becoming an issue, and it's an issue that is undercover. So we are looking forward to hear or to respond first. Okay.
You can respond.
Okay. Thank you, my reviewer. Very insightful. The points that you have actually raised. These points they will be taken in serious consideration when I'm developing full protocol. Indeed, there are some areas that I need to polish, issues of psychosocial definition conditions, and as well as maybe looking at the regulation processes. But primarily looking at the primary outcome on the suicide ideation, that also will be looked forward. I've read the last part, the benefit that will add as a literature. That one definitely I will add as well. Thank you. On the suicide ideation, I think that one will be defined from at first on the specific objective. I will define it as maybe probably someone who thought about ending their life following the online betting outcome, probably negative outcome. That would be, let's say, they have been thinking about it for the past 6 months. That will define suicide ideation. I don't know if I'm clear on that one.
Thank you. And I think just also as you go forward to also think about if you're going to ask about suicidal intent, that's maybe just something to keep in the back of your mind as well. Thank you so much.
Thank you.
Yeah, but only 2 minutes for comments on this. Okay, here's the Emily.
Thank you so much for this presentation, Lisa. I just wanted to follow up on the issue between suicidal ideation and gambling. Just make sure that your definition sort of encompasses the same timeline. So if you're gambling, please remind me of the gambling definition. I think you said you were paid so much in the past 3 months. So you don't want your suicide ideation to go over the past 6 months, because if you do get suicide ideation in 20% before, it's just not that you could infer suicide in any case, but it would just be good to keep that sort of in mind when you define suicide ideation.
Sure. Because in my, I would say I would define gambling as they are attempting 4 times in a month, at least putting money, $5 as a stake. Then that should be for the past 3 months. So indeed, if I'm defining the suicide, then I should be within that.
Yeah, not that you can infer suicide in any case, it's the bisexual setting, but just say that.
Thank you. Why not?
Thanks. So my question is just maybe, because I don't know a lot about this topic, but I know that recently gaming addiction was added to the list of specific disorders, but gambling, so I know gambling addiction is a mess disorder, but it would just be interesting to know in your introduction when you write stuff about what is the current thinking about this as a behavior and as an addictive or something with potential for addiction. So you can maybe outline that first. Maybe if you know, you can tell us now, because I'd like to know. But how is it defined of what is the behavior or what is classed as a mental health condition?
I think that for that one, that's very good questions. That's a very good question. I think we'll discuss later if we can manage it. I need to go back. I'll go back my supervisor to discuss that one.
Right on track.
So our next speaker is going to be Beatrice Chatala, all the way from Malawi, and your presentation is going to be virtual. So we're going to listen to the recorded presentation, and thereafter we're going to follow the same process. And she is being supervised by Professor Sopstar. Thank you.
Good morning. Greetings from the warm heart of Africa, Malawi. I'm Beatrice Cynthia Jidara, and I'll be taking you through my research protocol that is entitled Perspectives of People Living with Psychosis on Personal Recovery in Zomba, Malawi. That's a qualitative study. My study is being supervised by Professor Catherine Kosorta. So, psychotic disorders are mental disorders that are characterized by having hallucinations, delusions, disorganized speech, and disorganized behaviors. They are one of the mental health conditions that substantially contribute to the burden of disease. Yes, they are not in the typical common mental disorders, but they are also there to contribute to the burden of disease. 7 in 100 people globally will actually develop a psychotic disorder in their lifetime. And in Africa, there is a lifetime prevalence of around 1 to 4.4%. Talk about Malawi in particular, we have a record of around 30% hospital admissions that are due to schizophrenia. I may not talk about the actual prevalence because it is not well documented. Over time, issues of recovery in mental disorders or psychotic disorders are becoming an emerging issue. There's been a shift from clinical recovery based on the biomedical model of care to personal recovery, which is more centered on the person and what they experience and what they call it to be called recovery. Recently, a study was conducted where personal recovery has been explored through the eyes of stakeholders like mental health professionals like doctors, nurses, and also community members. There is a gap in exploring these perspectives because none of the people living with psychosis has actually been engaged in trying to learn what exactly they conceptualize recovery, personal recovery as. This study at hand is now there to bridge that gap by studying personal recovery in the eyes of those that actually experience it, giving us room to tailor interventions and everything else in perspective of the person himself. So this study aims to explore the perspectives of people living with psychosis on personal recovery, that is in Zomba, Malawi. And in particular, we will seek to understand how they conceptualize recovery. We will also seek to identify what they perceive as indicators of recovery, that is from psychosis. And apart from that, we'll also learn from them on what they perceive as the facilitators and barriers to recovery. In terms of methods, as we said, it's more of digging deeper and deeper. So we'll be using the explorative qualitative study design. And as we'll be reporting the findings of this study, we'll also be in check of the consolidated guidelines or checklist to qualitative studies. The setting, we will be studying from Malawi, which is a country in the southern sub-Saharan Africa with a population of 19 million. It is also one of the low and middle income countries. As it said, it has 3 regions, and Zomba, the actual place that we are conducting the study, is in the southern region. And Zomba Mental Hospital, the actual place, is the only public mental hospital in the country. It offers services like inpatient to almost 400 people, outpatient for several people, that is including those that come for subsequent reviews and those that come for the actual diagnosis. It also offers rehabilitation to those that have suffered mental illness. So the study will be conducted at the outpatient department of Zomba Mental Hospital. To be engaged in this study as a participant, you should be someone who has a diagnosis of psychosis, that is any diagnosis that is found or is from the family of schizophrenia spectrum and other psychotic disorders. You should be somebody who was diagnosed 6 months ago or more than that. And also, you should be attending the outpatient services, and you should be an individual that is more or is 18 years old. And also, you should be someone who is willing to actually get engaged in such a study. For one to be recruited, we will not just get to the recruitment. It will be a process. And the process will begin with seeking research approval. That is from University of Cape Town in South Africa. Then we'll get to Malawi. You can't involve the citizens of Malawi into your research without consulting with their research bodies. And for sure, we'll seek approval from College of Medicine and Research and Ethical Committee. And apart from that, we'll also involve the Zomba Mental Hospital, since it is the place where we'll conduct the study. And after they've given us approval to conduct the study, then we engage the mental health workers in the outpatient departments. To be precise, those that are engaged in the review of crimes. For example, the nurses, the clinicians, and also the psychosocial counselor and social worker. They'll be told about who is eligible, the study objectives, and also the recruitment process itself. Once they find somebody who is eligible, then for sure they will refer this person to the research team. We'll have a team of individuals that are qualified and experienced in conducting research. So the individuals, the participants will be referred to them, and they will be engaged in a brief talk where they'll be told about the study, and their willingness to participate in the study shall be explored. If they show willingness, then there'll be a schedule of the date of the interview. Approximately, we are planning to recruit around 10 to 12 individuals, but then this will depend on saturation point. Through the research process on the day of the research, they will meet these qualified researchers, and a briefing shall be made where they will be told of what is to happen, and formal written consent will be done. Apart from that, we should acknowledge that there will be data collection happening, which will be done by recording the semi-structured interview that will be conducted on this day. And apart from that, field notes will also be taken. The session itself, the semi-structured session, will actually have the beginning, the main body, and the end, which is more of building rapport, the questions that are focusing on the objectives, and then the end, which will be the concluding part of study. Thereafter, these people shall be reimbursed of their transport, and then refreshments shall be served. As I mentioned, there'll be interviews which will be guided by an interview schedule. This interview schedule will be developed, and after being developed, it shall be piloted before it is actually used on the participants. It will be piloted and its feasibility shall be tested. Once it's deemed to be feasible, then for sure we'll go ahead to use it in our research procedure. To talk about data analysis, what we should know is it will be done with the whole team. That is almost 3 researchers, including the supervisor, who will also be engaged in thematic mapping. Data will be uploaded on MPhil for coding and thematic mapping. As I said, 3 individuals will be involved in actually analyzing the same data, so that at least whatever they have as their findings or the things that they've actually made should actually be checked and seen to be kinda similar. Transparency and legal, for us to do a credible research study, there will be some couple of things being put in place. For example, we'll have several researchers on the ground conducting the actual research and the analysis. And apart from that, we'll also have different tools being used. For example, some structured interviews and the field notes. And also, depending on funding, there will be member checking happening where after the results have been made, the participants will be involved so that at least they can confirm the findings of the study. Apart from that, reflexivity shall also be engaged where the researchers will all have reflexive journals where they will actually keep a track record of what exactly they've been doing to limit biases. And also remember, we've said in our report, the consolidated guidelines in conducting qualitative research will actually be the one to guide us. In terms of ethical approval, in terms of ethical consideration, there'll be an issue of checking on ethical approval. Like I said, we'll ask for approval. There'll be the issue of informed consent. Our clients shall sign informed consent. Issue of risk and benefit shall be told to our clients, and when there is any risk, it shall be mitigated. And if they happen to experience any psychological issues due to the study, then for sure they'll meet psychosocial counselors that will be available in the hospital. In terms of privacy and confidentiality, that will be observed by having password protected devices that will be used, for example, the laptop, and also the offices that will keep the records shall have protection. That is all that I had for you. This far, I want to get some comments from each one of you.
All right, thank you so much. The trustees reviewer is Dr. Jacob, whom I believe that your responses for us. Thank you.
Thanks, everyone. So Roxanne Jacobs isn't well today, so I am going to be giving her her responses verbally. So she first says, which I completely agree, this is an important and highly relevant study towards understanding recovery among people living with psychosis in Malawi. It's an important topic and matches the proposed qualitative design very well, and the aim and objectives align logically, and your study seems feasible. The few suggestions that she had, Beatrice, and hopefully you can see me online, are just to strengthen your proposal and get you really ready for ethics moving forward. So the introduction section, consider using the term mental health conditions instead of mental disorders to align with person-centered language in the WHO recommendations. See comments on prevalence. She's put comments in the proposal as well, so you'll be able to go through in detail the difference between the prevalence generally and obviously hospital admissions data, which is quite different. This section describes recovery very well as subjective and personal, which is very true, but it could be strengthened by providing a definition of personal recovery as an evolving journey. The method section, under study participants, when you can specify can engage in local conversation as an inclusion criteria, do you specifically mean having the capacity to provide informed consent and participate in the interview? How will you determine that a participant is currently in a condition to give free and informed consent? For example, will you check for understanding, retaining information, being able to communicate that information, intentions, voluntary act on information? So really quite important if you're working with this kind of severe mental health population. You need a subsection under your ethical consideration, links to informed consent, and under procedure section, you need to specify at which point you were doing this particular assessment. So under procedure, remember capacity may change if someone provides their written consent, which when it was obtained, especially if there's that time lapse between the consent and the interview. So think about how, who, and when in capacity to consent when it will be assessed. Gosh, I've got a lot here. Under recruitment section, use your mental health professionals quite broadly. Please provide more detail on what this means. What this actually means, how they will be involved. So this is how you are getting your population, which is to go through the mental health professionals, to be very clear on who they are. Are they psychiatric nurses? Are they? Under the interview schedule, you can save on word count by minimizing generic descriptions of what the interview procedures entail. Great to mention rapport building, but the focus of this section should rather be on the contents of your interview schedule or going into your topic guide. Think about how your domains will be operationalized, subtopics to be explored. She does give some suggestions in your proposal, but also consider collecting more demographic information and other clinical related variables, which is probably very important at this stage. Data analysis, clarify who is involved in the analysis, if it's your supervisors, your RA. She loves the diagram showing that step-by-step thematic analysis, but consider citing more recent versions of Braun and Club. Under trustworthiness, be careful of use of the terminology used. They seem to be using inter kind of collaborations together. You have to make sure that all of it aligns with your strategies that are used for trustworthiness rigor. Consider more appropriate strategies when you're looking at reflexivity, journaling. You did mention number checking, but reflexive journaling, etc. Ethics, this section looks good, addressing consent, risk, and confidentiality. There's a few more pieces of information that should be included, but I've included it in the proposal. And lastly, a grammar check, good to be consistent throughout the documents. I think this probably applies to everybody, I think, at this stage. But generally, well done on bringing this together. A great concept, a great study in such a short space of time. I'm wishing you all the best in your study.
All right. She might not be here with us physically, but online she is, or she still needs to respond. She still need to respond in the Okay, Beatrice, you are being asked to respond to the reviewers' comments, and then after we're going to take questions.
Good morning. I don't know if you can hear me.
Yes, you can, Beatrice.
Hello. Okay. Let me thank my reviewer in absentia for the comments that have been made. She should consider that I will actually take a look at all of them, hoping they'll also be sent to my email so that I can actually look around and then address them all by strengthening my research proposal. But then I'm really thankful because it will actually help me to be in check with the actual write-up that I need to have. I don't know if I have missed any questions that were inside the comments, but then most of the things that I've heard are more of comments and not questions, unless I did not get that clearly. Thank you.
We still have to take a few minutes to ask questions, even though our audibility is not that great, but hopefully she will manage. Any questions for Beatrice?
I think mine is more of a statement than a question. I'm just speaking loud to Beatrice in EMP. But previously in a study that had a population of adults who suffered with schizophrenia, they used the UBAC, which is a specific tool that looks at capacity to consent to make sure that someone's not actively psychotic in that stage of recruitment. So maybe you could look at using that throughout different stages to assess capacity to consent so that they still understand. So it's just more of a statement.
All right, thank you. Okay, hopefully you were able to hear that statement, Beatrice, or if not, I think we can still follow up because auditability is a bit of a challenge. Thank you.
Yeah, I did not really get the question clearly.
Okay, it's fine. We'll follow up. We'll write it down. All right. Our next speaker is going to be Julius Mango, who is also from Malawi as well. And he's also being supervised by Professor Sorsdal and Professor Dr. Keda as well. Over to you, Julius.
Hi. Good morning. So I'm Julius Mango from Malawi. I'll be presenting on this proposal, building life after suicide attempt in northern Malawi. Look at individuals and families' experience. The survivors are Professor Catherine and Dr. Rihanna. Mainly, I'll draw on the rationale of the study, objectives, methodology, and finally conclude with the ethical considerations. Rationale. So suicide is a global issue, a global phenomenon that is rising, but not all suicide are successful. Some of their attempts, and these, when you attempt suicide, we call suicide attempt survivors. And suicide attempt survivors and their families, they face a lot of challenges, including psychological, social, emotional, more, and this mainly is also aggravated by stigma as well as poor or limited mental health support. So global studies have looked into suicide attempt survivors, their experience, and the like, using criminological studies, but little is known about this in Malawi. And for this reason, we'll be studying to explore the individuals and families' experience and the life and the life after a suicide attempt, which ultimately will generate a context-specific evidence. At the end, it will help to have a sound policy in mental health in Malawi. Broadly in objectives, so the aim is to explore the lived experiences and help seeking pathways of suicide attempt survivors and their families. More specifically, we'll be targeting to explore the lived experience of suicide attempt survivors and their families, also to identify formal and informal help seeking pathways, as well as to describe the perceived barriers and facilitators. The methodology. So this study will mainly be qualitative, and the design will use the exploratory design with the aim of gaining an insight and clarify some concepts as well as explore meanings. Normally, this design is used when the legal is known. So, suicide being something that is also of legal interest in Malawi, and legal is known, therefore, this design really suits. The setting is it will be done in Malawi, specifically in northern region. Malawi has a population of 22 million, and this study will cover at least 6 districts. Participants will have 2 groups of participants. We'll have the suicide attempt survivors, and then we'll have family members of suicide attempt survivors, those who will be included in the study. Malawi. So this is the map of Malawi. If you look from, this is the map, the whole map of Malawi, and the second, the study setting area. So this is the northern part of Malawi. So normally, mental health services remain under-resourced, and normally they are centralized. In the northern part of Malawi, we don't have a mental hospital, and the only hospital we have is a private-owned hospital, which nobody can easily access. And these mental health services are offered through district hospitals and few primary health care, so we call them health centers. And also being a challenge to say we have limited trained mental health personnel, including the psychologists. We have very few, and this makes even the follow-up of people who survive suicide to be a problem and be inconsistent. So the setting is chosen because of its poor mental health services, accessibility. I'm also looking at it as a strong community structures, networking, as well as the cultural diversity. And this provides a complex environment where we can be relevant to do a context-specific information. Inclusion and exclusion criteria. So we have 2 groups of participants that will be involved. We have the suicide survivors and their family members. The inclusion criteria for suicide survivors will be those who are 18 years and above, and those who at least survived suicide for the past 6 to 24 months. We will leave those who are less than 6 months for emotional distress, and those who are more than 24 months for the sake of having recall bias. And for the family members, and we also exclude those who are actively suicidal. For the family members who get those for 18 years and above, and then family members of those who be involved are only those who have been identified by the participants and also live in the same household. And we're going to exclude minors. This sampling techniques will be purposive and to be specific for the participant will be criterion based. So in this case, the healthcare providers will be able to identify potential participants. So health personnel identify and inform potential eligible individuals about the study. And then we are expecting to recruit at least 12 to 15, but we keep on pushing until the saturation point is reached. For the family members, this will be a referral form, and these will be referred by the participant, and the participant will be able to identify the member who is supposed to be involved in this study. In all of these, only family members, only researchers will only contact with them only if the individuals are interested and have given a permission to be contacted. Those who will not give permission will not be contacted or followed up. So the recruitment process will be, first of all, we're going to have ethical approvals both from South Africa and Malawi, and then we'll have the stakeholders engagement meeting. We aim to have stakeholder meeting with the Northern Region Health Office, district health offices, mental health professionals, including counselors, clinicians, and nurses, who are mainly involved in the mental department. From there, these professionals will help us in identifying potential participants, such as suicide attempt survivors, and they will be able to brief them. And if they accept to be involved in the study, and this brings me another step. So if they permission to accept to be involved in the study, the information will be shared by the research team, and the research team will make a contact. And this contact we are planning to do through the phone call. With the phone call, we're going to provide more information about the study. If the participant accepts, we can also inquire if he can ask a family member to be involved in the study. If accept as well, then we'll arrange for the physical meeting. Now, after the physical meeting, we're going to do the yes. Now at the physical meeting, we're going to have individuals also having able to say which person they want to be involved, and we're going straight to that area and do the interview. And everything will be explained, the purpose, the potential risk, benefit, and the like, and then consent will be obtained by printing or signing, as well as the interview will be done, and each week interview is expected to take at least 5 to 60 minutes. And the data will be audio recorded and then transferred into the MPhil and will be analyzed thematically. And we're trying to do two-coder, I'll be coding, and my supervisors also be coding for the initial part, and then I'll proceed. We understand that this also being a qualitative research, we need to be the study should be trustworthy and rigor. So issues of credibility will be looked into, transferability, dependability, as well as the conformability. Reflective will also be used in this the study, especially with interaction and the way we interpret. And the final part is looking into the S consideration. So the S consideration will look into data safety, how we're going to manage our data, protecting the data not accessible to everyone, and potential risks and discomfort. We yes, they may be emotional, but we're able to split them using suicide scale, or the suicide scale. And potential benefits, they are not direct benefits, but the information they provide will help us to build some evidence based. And consent will be formed, will be signed, and the rights will be respected. Privacy as well, we're taking information as well as investment based on the participation transport fare. Right? Otherwise, this might be the end of the session. Thank you.
Thank you so much. And our reviewer for this study, Professor Shakira. Thank you.
Hi, and thank you, Julius. The first thing, it was a very nicely written proposal. It's clear, it's logical, it's easy to read. So congratulations on that. And I have sent Kat some little comments electronically, which you can forward to me as well. I think in your fuller proposal, as you develop it, you need to explain why the services can, what services could be provided. What are you trying to influence? What is realistically something that could be provided afterwards? And also look at what's being done in terms of prevention and post-attempt intervention more globally, especially in other low-income countries. If I remember correctly in your proposal, you said that it's a criminal offence to attempt suicide. Is that correct?
Yes.
So I think that's quite a useful thing to think about in terms of the sensitivity of recruitment and a whole lot of issues around that. And maybe your study is about helping to change the law as well. So that might be something to think about, how you could influence that process. I don't know whether there's already a process in place for that law to be changed or to be gotten rid of, actually. In terms of the methodology, I'm a little bit confused about focus groups with the families. Okay, but before that, also, you need to specify how you're going to determine if somebody's actively suicidal. You need to, are you going to do a scale? I don't know what the scales are around suicidality, but then there must be some. In the focus groups with families, I think you need to expand a little bit. I wasn't quite clear what was, so sounds like from your presentation it's one. So if you recruit 12 suicide attempt survivors, you're going to have 12 family things. Maybe something to think about is potentially having a friend who might be much more understanding of what the person's going through than maybe the family, who might be more dismissive or may have other attitudes. I don't know, to think something like that. Does it have to be somebody who's living in the same house as the person? You say you're going to run a focus group. So I don't know how many focus groups and where they're going to be and all of that. So you need to add that kind of detail. But bear in mind that a focus group could lead to disclosure of the person having attempted suicide, even if they're not in the focus group. So potentially think about that quite carefully and make sure that you deal with it effectively. I'd really like to know what your role is. You didn't say who you are. Okay, and I haven't been part of the MPhil lecture, so I don't know who you are. Are you working in the area of mental health? Are you working specifically around suicide? Add a little bit. And linked to that is your point about having field notes and reflective journals, which I think is a really nice idea. But how are you going to include that in your analysis? If you're going to be bothering to do that, include that in how you're going to analyze the data as well. It's a source of data as well. So think about that as well. But other than that, I think it's a very nice proposal. I think it's clearly an area, given that it's a criminal offence, I think it's a very sensitive area. And the ethics are going to be really something you need to deal clearly, and how you do the interviews. And your consent form will have to reassure the survivors that you're not going to report them. Those kind of things. So that's my comments.
Okay. 20 minutes to respond to the review of this.
Sorry. Okay. Thank you so much, our reviewer. I think those are very good comments. I'll start with my role. So I'm an MPhil student, but back home I work as a national NC and mental health programs officer. So I've got experience on how I really an interest after interacting with how we work in my environment platform in Malawi. So I'll start with the mandatory report. The report. So the effort of the other parties look into the mandatory reports. As research team, we don't have the mandate to report the past attempts of society. However, in our assessment, if we find that someone is having active society ideas or in active way or part, what we're planning to do is we have the duty as researchers to promote good and through the principles, ethical principle of beneficence, non-maleficence, we still need to refer the case in this part. The data analysis part will also be looked into details, especially on the like in the full proposal. And then the other thing was on the focus of discussion. This is part that we also had a discussion with my supervisor about how best we can do this. So our initial plan was to do the focus group discussion with family members, but then we changed to say we're going to do the in-depth interview individually, not as a group. So we moved that out. Thank you. But I think if I forgot some of the information, I think those are the suicide part says how are we going to do the suicide part to assess whether we are going to assess someone who is active or not. We have a certain tool called the Colombian high risk suicide scale that we're going to use. If we screen using that one, if the participant is a potential in active suicide, we're going to not continue with the interview. But those who are not, the one who proceed with them into the interview. Thank you so much.
Just one question.
Thanks very much. It's a really interesting presentation. Just a couple of questions from my side. One is around the decriminalization of suicide. It's a very important policy issue. And there have been some quite recent victories in that. So Pakistan has just decriminalized suicide, which is a massive achievement. Countries around the world are working into this. So if you could write into your introduction and essentially the recommendations of your study, how would this influence or how would this help to decriminalize suicide? And the one other question I had was about the time frame. So you're interested in people 6 to 24 months after suicide attempt. There are always consequences for every study design decision. So that decision means you might miss people who've recently committed suicide and miss important knowledge about what their mental health care needs are. So if you could consider including people who made more recently made a suicide attempt, that might give you some insight into what people need immediately after a suicide attempt. It's just something for consideration. You can say pros and cons both ways. That's something for you. Thanks. Great advice.
Yes. Yeah, another question. Hi, I was wondering if you're going to identify patients with diabetic ulcers. Is that correct? How are you going to identify potential participants?
Okay, so we are not going to identify. Thank you for the good questions. I think I'm going to start with the last question. So we're not going to identify participants using the patient files, but we're going to use the health personnel. So the health personnel, these are professional mental health who may know someone who attempted suicide, and they were able to provide the information. We give them information sheet, and they'll be able to brief the participant, the potential participant at that level. If he accepts, it's only followed when he has accepted to be followed down.
So I would imagine that data might not be included in the files, legal sheets, right? Yeah. Is there a duty for healthcare professionals to report persons? I'm saying we're a system where you're admitting a person, say for example, you use resuscitation after a suicide attempt. How does the healthcare system interact with the criminal justice system under circumstances?
Thank you. So providers do not have the obligation to report. Their duty is providing the services. The other part of what they want to report is up to the participants, and then the individuals and the family will do the report, and other people have other social laws. But reporting is not mandatory in FA care provision. So we don't report. But maybe the record can keep say someone suicide, but we don't have obligation to report that.
Situation of having to report.
Yes. So it's true that in Malawi, suicide is illegal. And actually, I was looking at the 229 or 0701. It's really illegal, and if you are found, then the sentence up to 2 years imprisonment. So this is one of the reasons why we have a lot of people who have attempted suicide, but they have not been reported because of fear of illegal implication at the end. So the understanding is people commit suicide, but we don't have enough evidence on that. So still looking for that. But your point is very good one. I'll take note and I'll incorporate into the introduction. Thanks so much.
Our last speaker for this part of the session is going to be Mundai Masari, all the way from Zimbabwe, who is supervised by Professor Panabesnezen and Dr. Jacob. Thank you.
Good morning, everyone. My name is Mundai Masari, and I'm coming from Zimbabwe. My protocol title is Family Caregivers of Children Living with Autism Spectrum Disorder in Harare, an exploration of experiences and support needs. For the background, autism spectrum disorder, and in this case, we're going to be using the acronym, which is ASD, is a highly prevalent neurological disorder that is characterized by communication impairments, intellectual disabilities, and repetitive behavior. Children who are under the age of 18 are going to be considered as children living with ASD. And according to the World Health Organization reports, 1 in every 127 children has been diagnosed with ASD. And the prevalence tends to be higher in boys, as 1 in every 100 boys, 4 in every 100 boys have a prevalence of ASD, and 1 in every 100 is also a prevalence of ASD. Yeah. While prevalence data highlights the scale of autism, while data highlights the scale of autism worldwide, there are gaps in African research, and there are few studies that have looked into other associated factors that comes with the diagnosis of ASD. And research has highlighted that in Africa, there is lack of diagnostic tool, lack of assessment due to lack of resources. And this has even kind of raised the case of taking care of the children with ASD into the family care. So family caregivers have taken up the role of providing active role in providing caregiving to children who have been diagnosed with ASD. And due to insufficient institutional support, caregivers have become a primary source of care, making their role central to understanding caregiver and understanding the role of autism in African context. In this study, we are going to define a caregiver as someone who's got an active role or who is fully responsible for the child diagnosed with ASD. They do not receive compensation and they have no training in caregiving, and this includes parents, siblings, cousins, grandparents, and other relatives. And also they have everyday experiences in providing care. Research has also indicated that this caregiving role also comes with its fair share of struggles, and this may include psychological factors like emotions, beliefs and perceptions, social factors, relationships, and cultural norms, which also affect caregiving roles. Now moving on to our aims and objectives. The overarching aim of our study is to explore day-to-day realities and support needs of family caregivers of children living with ASD in Harare. And our first objective is to explore caregiver experiences of accessing healthcare and caring for children with ASD, which are going to look into economic, emotional, health, and social care experiences. Then the third objective is to describe caregivers' views on existing and needed support, skills, knowledge, and training. Okay, and the third one is to elicit caregiver recommendations for culturally responsive interventions and policies. Now we move on to the methodology of our study. Our study is going to be an exploratory qualitative research where we are going to be looking into the lived realities and making meaning out of the lived realities of caregivers. We believe that this qualitative approach is going to foreground caregivers' perspective and illuminate complex emotional and social and economic cultural dynamics. This is our study setting. This is one of the largest referral hospitals in Harare, and it's a central hospital which is called Parenyathwa Hospital, which means it houses a number of departments, and this also includes the child psychiatric department. Unfortunately, due to resources, we do not have an inpatient for the child psychiatric department. We only have an outpatient department. And in that outpatient department, at least 20 children or at least 20 patients are seen at every clinic, and always have 1 to 2 clinics per week. This is where the parents bring their children for assessments, for rehab, for therapies, and we are looking into taking the opportunity to screen our participants when they come for their clinic visit without interfering their normal clinical routine. Okay. And for our participants, we are going to consider purposive sampling, because with purposive sampling, we will get the right characters of participants that we are looking into with lived experiences, which will then bring us newest experiences and contextualized information that truly reflects our objectives. And we are looking at 15 to 20 participants until data saturation. For the exclusion, we are looking for the inclusion criteria. We are looking for full-time family caregivers. This can be parents, this can be siblings or extended relatives, but they should be 18 years and above, and must also co-reside with a child and provide direct care for at least 2 months prior to us being with them. For the exclusion part, we are not considering paid givers or trained givers. We're not considering occasional carers. This can be visitors who come in and go. And we're also not considering non-attendees of Parenyathwa Hospital services. Okay. Now we're going to move on to the recruitment procedure. We are going to get our ethical approvals from the UCT, Human Research Ethics Committee. Then upon those who get this approval, we're going to the Medical Research Council of Zimbabwe, then the Joint Research Ethics Committee. After that, that process is done, we're gonna get the approval from the medical superintendent of Parenyathwa Hospital. Then that approval will usher us into the hands of the matron in the child psychiatric department. We are hoping to schedule a meeting, and that meeting will be an introductory meeting where we will present the research team, will present the study, and we're also hoping to seek some offices and some space to use while we are doing our study. And we're also hoping to discuss asking for help for the clinic linkage officers and the nurses who are going to be assisting us in identifying potential participants as well as referring them to us. This also process will also help us to link and coordinate, as we are going to be having probably referrals later on in the study. And the research assistant, the linkage officers, and the clinical nurses will help and assist in recruitment. Then we are going to do, upon this process is done, we are going to have leaflets and pamphlets or information sheets that we are going to distribute during the clinic, early morning clinic visits where sensitization is usually done. We'll present our study and people can read through the leaflets. And if there are any questions or any queries, they can come now to us and say they are interested in the study. So that way it's going to help us to identify willing participants without the fear of being recognized by everyone. Then through the eligibility screening, we're just going to be looking at their age and just collect some biomarkers that can help us to screen for eligibility. Then those who are eligible, they will go through to consent form. After the consenting form, they'll have the interviews in the private space. Then our data collection is going to be structured, semi-structured interviews, and we're going to be looking at the domains that we included in our objective. For thematic analysis, you're going to use reflective thematic analysis following the Brown and Clark 6 phase, and we're going to use NVivo is supporting our code and team development. And from there, we are going to, trustworthiness is going to be shown through credibility, dependability, transferability, and reporting guidelines. And as for our research ethics, as said before, we're going to seek approvals, do informed consent, assess risk, benefits, then we do mandatory reporting as well. So thank you so much for the presentation.
I think so much for the review of the studies, Doctor. Thank you. Thanks, Norma. Well done. Thanks for the reply. I'm Rona Perry, most of you know me, but I'm from South African Research Council, a researcher in the mental health research. And I've been involved with lots of the inputs for many years to be here. So well done. Your proposal is really nicely written and the presentation is very well done. Most of my comments are for things for you to discuss with the supervisor, just to kind of maybe deepen some of the literature review and think about some of your methods. I have to say I have the same question as Marty. I wanted to know, who are you in this hospital? Do you work at the hospital? Are you an OT, or what's your role? So although this is an academic piece, the ethics reviewers will want to know who you are. A little bit of background. It also helps them to understand your access to the hospital and clinics. So it's really nice to see the study about caregivers, first of all. So I think that topic and the area is really important. I think that in your proposal you talked a little bit about the cultural aspects of caregiving. I think you can unpack that a bit, because when we hear that, we think, okay, African identities and immunity and fashion and all of that. But what you do also see sometimes with people that have special needs is that actually it does fall very much just to one person. So that the experience of caregiving might not be that different to, someone in a more Western context who has a very high level of responsibility. And I also think maybe in your literature you can look at, they talk about caregiver burden, but in a way things are moving away from speaking about it like that, because that's quite stigmatizing towards the children or the person with a mental health condition, and also because there are lots of really positive aspects of caregiving, so people get a lot of meaning from it. So perhaps when you're asking your questions and doing your interview schedule, you can ask the questions more broadly and open-endedly about what is your experience, what are the different things that you get out of it, what are the pressures that you have to respond to. Okay, and then, oh yes, your full-time caregivers. So that's your inclusion, but how do you define that? What does that mean exactly? And do you think you may be limiting a bit by saying it has to be a full-time carer? So if we're saying that it is a different kind of caregiving where people are more involved, what does full-time actually mean? And also it's a question that we often, these type of qualitative studies we often have, where in your proposal you talk about using a purposive sample, which I think is right and good, but when you're actually looking at the sample, how are you doing that purposefully? So is it just actually a convenient sample of the people who come into the clinic and who agree to it? So the purposive sample could be based on, often it's around the amount of time they've been in the role, kind of thing, with the experience. And in your proposal, you talked about 2 months as a caregiver being the eligibility criteria. And I would suggest that maybe that's a bit too short. So maybe you could try and think about someone who's been in that caregiving role for a bit longer, like a year or something like that. What else? Oh yes, are you going to have any inclusion criteria based on how old the child is? Because you can imagine that the experience is quite different depending on how old the child is. And oh yes, this is also probably for lots of the people doing qualitative research. I know we always talk about data saturation, and reviewers want to see talk about data saturation, but really it is something that is being, kind of challenged quite a lot now. So what is data saturation actually? And you're saying you'll keep sampling and coding until you have data saturation, but really,
what does that mean? And so when you're reading up some more and doing your methods, I would encourage you to look at this concept of information power, which is more about you choosing people to interview who you know will have the richest experience. So you're not just talking about the coding being a way to know that you've got all the themes. There's could be different themes depending on who does the coding. So I think that's probably enough. I have one more comment or idea. I think it could be interesting in your sociodemographics to look at what is the person's sort of role in the wider family. So, for example, are they an eldest daughter? Probably a lot of them are, or are they an aunt, or what is their role? I thought that also, oh yes, the big one, your objective. So your objective sounds like it's about, you're going to be asking them about their experiences of healthcare, interaction with the healthcare system, which I think is a completely valid question. But then from your background and the way you're looking at it, it seems like you're wanting to understand this caregiver experience more broadly. So the financial, the economic, all of that. So I would suggest maybe we'll think about, you could possibly change that objective to be about caregiver experience more generally, not just about the healthcare system. Thanks. Well done.
Thank you so much for the feedback that was quite insightful, and most of the issues that you brought forward, we are hoping to discuss them with my supervisor when we meet after this. And in terms of my situation, how I know about the autism clinic, I'm kind of work in the psychiatric department. So through our meetings and our programs like this, we always meet and discuss. So that's how I know much about the psychiatric department. And regarding the cultural aspect, I think it's a valid point, and I'll discuss it further, because from my understanding, I was not talking about I was coming from an African perspective. Generally speaking, about Zimbabwe itself, there's a lot of like stigma. Like if you have a child that has got a disability, it's not easy for you to just come out. So that is the context of culture that I was talking about. You having just a person disclosing that I have a child that has an ASD diagnosis, how does that affect them? What is that they're experiencing in disclosing that to the people? So that is the culture that I was referring to. But I will refine that with my supervisors. Then in terms of literature review as well, we will take that into consideration, because when I was doing the background, there's been just like an overlap of information between how to then kind of touch autism, looking at autism, then touch it from caregiving. So it's something that I will need to look into. Then also pointed out about defining what a full-time caregiver is. This is something that I will actually discuss with my supervisors. There are cases that we are going to see 2 primary caregivers for 1 child. How then are we going to define who exactly is a full-time caregiver? It's something that I would need also to look into, then probably have a screening or look into other demographics that can then define who exactly we are including in the study. And for the sampling, I may have said it's 2 months, but we are saying at least for the last 2 months, they should have stayed with the child together. But prior to that, they would have lived, but at least in the last 2 months, they should have lived in the same house with the child. And also on the issue of inclusion based on health of the child is something that we're going to consider as well in the full protocol. And according to the research that I've been doing, our data saturation, we are going to achieve it until we're going to continue recruiting. At least if we get to 15 people, we can still recruit a bit more until no more new things are emerging. That's how we're going to reach out to data saturation. And each aspect of social demographics, we're also going to take that into consideration.
This is the first question, second question there.
It's a lovely study and very important. I just wanted to draw your attention to 2 or 3 things. The first thing is just around, so I haven't read your proposal, but I'm sure as you engage with the literature, you might see some of the tensions around how what to name the group. So there is a bit of a tension between, is it the neurodiversity first or the individual first language? So, and much of the conversation now is that it's the neurodiversity is the individual's identity. So in that instance, instead of referring to children with autism, it's autistic children. So it doesn't, as it is as part of who they are. So maybe just have a look around at that. The second thing is, again, I haven't read your proposal, but I'm hoping that you have spoken a little bit about, because of the nature of autism and it being on a spectrum, that caregivers are likely to have children who are perhaps high functioning or children who are not functioning well with autism and need perhaps a lot more support. So you may want to just distinguish, if this sounds more exploratory and that might not be the criteria, but I think when you capture the demographics or the information, that you also try to determine the level of functioning and to look at those experiences. And then the other thing is just around diagnosis of autism, to also be mindful of in the literature some of the tensions in the broader community around DSM diagnostic criteria versus the broader essence criteria that are also used for neurodiverse individuals. Let's see, if that may be worth having a
look. Following Mary's question about the age of the child, I don't think it's a problem to have varying ages. I think you need to document it, because you might have very different care needs in your age. And time since diagnosis would be quite important, and maybe the process of getting a diagnosis might be quite useful, especially within the health service. And then you've got economic, social, but you've got to include education. What is the access to education, especially early childhood education for the younger ones? And then later, because the health system can do that much, so much, but the education system becomes a crucial one. So I think it would be useful to you.
Thank you so much for all the present and ideas.
Well, I have one of the singles, though we are not doing that very badly. I'm aware that you are attending to the viewers who are online. I'm not sure if there's anything that you'd like to bring to our attention. If not,
thanks, there are a few comments. I think there are just a few suggestions that I can pass on.
You can pass
on. Yeah. For one,
there's a couple of papers from you that people have suggested, so I will pass that on to you. And then Jonathan was just suggesting that you maybe consider people who do not access services as well, that don't actually attend services, that it'd be useful to possibly interview them to understand the barriers to accessing care. And yeah, Tara had a question, but then she said you'd answered it, so well done.
All right, thank you to everyone, both online and here. So we are going to take a break and we'll be back at 5 minutes past 11. I believe that for the people who are here physically, there is some coffee station for us to get something to drink and to stretch a little bit. And we'll see you at 5 past 11. Thank you.
So just in terms of my connection with the work, I'm part of the psychosocial team at an NGO just down the road, the MPhil, and we do specialist pediatric palliative care work, and we also have a neonatal palliative care program here at the moment. Right. So when we speak about neonatal death, it is defined as a death after live birth during the first 28 completed days, and whereas a perinatal death includes stillbirths and the death of the baby between 26-week gestation and less than a month old, and my study will be looking at both of these groups. So infant death is really a significant public health problem, and although we are seeing trends that are improving internationally, there has not been significant shifts in sub-Saharan Africa. So in 2025, the WHO statistics reports shows that the global under 5 mortality rates have declined by more than 52%. However, so that's a decrease from 10 million to 4.8, which seems significant. However, in 2023, just the African region accounted for 55% of the global under 5 deaths, and sub-Saharan Africa had the highest neonatal mortality rate, accounting for 43% of the deaths. And the stats in South Africa also show quite a concerning picture. In that time period between 2016 and 2000, there was about an increase of 1,000 deaths per year. We know that mothers who experience a neonatal and perinatal loss have a very high likelihood of developing mental health conditions. We also see in literature that there is really a gap in context, South African context being represented. I do want to say I've also since noted that the perinatal mental health project is also producing local research. And another gap is also that a lot of this research focus on in-hospital experiences, where my study will be looking at the process after discharge. So in keeping with that, the aim of my study will be to explore the lived experiences of bereaved mothers who suffered a loss in the perinatal and neonatal period. Then my first objective is to explore how my mothers experience the changes in identity, relationships, and mental well-being following this loss. Secondly, to explore their experience of the provision of services provided for the physical and psychosocial needs during this time. And lastly, to elicit recommendations for strengthening of available services that can meet the needs of the system. So the methods that I will be using will follow an exploratory phenomenon design. I'm glad I had that written down. Can't say that word well. And in terms of my setting, we will be focusing on perinatal and neonatal care within the public health sector within the Western Cape and South Africa, and we will also focus prelims on tertiary settings. And the reason for doing that is that these institutions are referral hubs for high-risk pregnancies, labor complications, and specialist care. We are also exploring engaging with other NGOs and service providers in these spaces. So just to answer that question, annually there are approximately 60 to 80 neonatal deaths just at Mowbray in the neonatal unit. So, and that is excluding miscarriages and stillbirths in obstetrics. Participants will be bereaved mothers between the ages of 18 and 40 who've experienced neonatal loss. And there's more specific inclusion criteria is that they would have to have an in-hospital neonatal death with a minimum of a 7-day admission for the baby. There's occurring a maximum of 2 years and a minimum of 6 months prior to the interviews that will be done. That they must be proficient in English, Afrikaans, and Xhosa, and also that they would have received services within the public healthcare sector, so no one that has private health will be included, and of course, informed consent. We are anticipating having 12 to 15 participants. Yes. Okay, participant recruitment. The study participants, I wanted to say, go back. I would have said until data saturation, but I will now replace that with until data power has been reached. I do know. All right. So in terms of participant recruitment, I think an important point that I want to be clear on is that we really acknowledge that the process of participant recruitment will most likely be quite a steep and complicated process. In my study, recruitment strategies are really still being explored, and we will be consulting with clinicians and researchers with their expertise in this area. So after obtaining the necessary ethics approval from UCT, Department of Health, and also the individual hospitals, we will have meetings with the head of neonate, the neonatal units, and all the relevant clinicians in these hospitals, where we will introduce the purpose of the study, and also important, strategize potential avenues for participant. An example of this would be that potential participants will be identified by the units and then be contacted by a psychosocial provider to ask permission for the researchers to contact them. Only the mothers who have agreed will be contacted by the researcher, and initially we will engage first by WhatsApp and then by telephonic conversation to introduce the study, inquire their willingness to participate, and then also doing getting verbal consent. A date will then be arranged for the formal informed consent process and for the individual process. So in my study procedure, will firstly include semi-structured individual interviews. It will be conducted in a private space, and it will involve obtaining informed consent, and will be conducted by myself. And then also in support of a EasyCloser speaking interviewer if needed. Interview schedule will guide the discussions, and we anticipate the interviews to last between 6 to 90 minutes. At this stage, we will also really explore the participants' interest in taking part in the focus group discussions, and if someone says no, thank you, then we should not reach out to them, and that will also give us a good gauge whether focus group discussion is actually. So focus group discussions will take similar formats, also being a private space. We will engage with the consent. Will be done by the same people as the individual interviews. We will be semi-structured schedule, and we'll anticipate between 60 minutes and 2 hours. So the interview schedules will be piloted and will be informed by the study objectives. They will also be open. Data analysis. So the verbatim transcription of the individual interviews will be used for the raw data analysis process. We aim to also use in vivo and include more than one coder in the analysis process. So the current proposal is to use Georgie's descriptive phenological and analytic method, but this is still under consideration. It's clearly outlined there. Also, just to note, once all the results are completed, I will also invite participants back to share the findings and explore whether the findings actually reflect what they meant to share, and this is also known as membership. So as we know, it is really essential to demonstrate trustworthiness and rigor through these 4 pillars. We are exploring strategies for these. However, I think reflexivity would be a really critical one and will be in the forefront during the interview process and data analysis. And imagine something to really consider in our context, something like power dynamics, for instance. And this can be done through reflexive journaling and also during the supervision sessions. And I will, like I mentioned, do Vivo and also compile an audit trail of the coding setup. Ethical considerations. Okay. And the standard ethical considerations will be made, but I just want to highlight 3 of them. In terms of privacy and confidentiality, this is always very difficult to do in a focus group setting, but we will put measures in place to see how, to what extent we can get this. Also, pseudonyms, the plan is not to use pseudonyms in the group discussions, but unique identifiers will be included in data analysis and right applicable data. Participant distress is, of course, another one. I've got skills to, in the moment, contain, but then we will also have a planned referral pathway that that will be offered to where they can receive support. And then the last one, in terms of compensation for the interviews, we will be offering compensation or transport and reimbursement, and refreshments will be made available. And then also at the end of the individual interviews, we will give participants 150 rand and grocery voucher. And this will be given to them whether they want to do further discussions. So that is my story.
Thank you for getting your hand right, Professor Robert is here, so we'll be able to provide some input.
Very glad to do this work. I don't think I'll be able to handle it. I had a read of the two qualitative papers that you cited. You just find the titles alone. I did everything I could, and was not keen to leave the work from India and Uganda. So this is definitely not the easy topic, as is all of the other topics that have been presented this morning. And I've got some comments on the draft which I'll share, but one of the things, the main thing I want you to think about is, this is now one of your main justifications for this work is that you know very little about the bereaved experiences of mothers in the South African context. That's important. But what I would want you to challenge you with is, from the literature of which there is some, what still remains poorly understood? Because what I gathered from those papers is that there's the perspectives of fathers and mothers too, is that, of course, these experiences are really different, isolating, ostracizing, because, especially with the in-laws, there's challenges around, you're not being a good woman because this child has died, and all those things that sort of came out there. And if your study is to document these experiences too, that we're saying more of the very isolating, the difficult experiences, but then what else? And so it's one thing to document these experiences, which will come out from the interviews, but I think one of your objectives, objective 3, which is around their recommendations, but then also objective 2, around the services, is, I would almost say, instead of a focus group, unless focus group really is distinct in what it's going to ask of these mothers on their experiences, so that you're not having to have them in a group setting now recount these experiences once again. That you think about either looking at a family member's experience too of their perceptions of the support and their experience that they were going through, or actually to, in these healthcare facilities, speak to healthcare providers. Because part of what you want to do is to try and figure out how best to improve the services or the support and the care around bereaved experiences. And so if we're only ever getting what women went through that is harrowing, and what exists, what can we, from the perspectives of clinicians, and how can we from there see it from their side to see, how the other things that are coming out of the literature is the difficulties that healthcare providers, and there is that power around, how to interact with that. So I wanted you to think about, especially for answering that service provision objective question, think about speaking to the providers too, rather than the focus group, where it's actually, for me, not yet clear how it would be different from the institutes. I saw you mention to get further in depth, whatever, which means that you expect them in some way to actually speak a lot more to the difficult experiences. Whereas I think, coupled with what they went through versus perhaps what is routine in these facilities, how do healthcare providers hit, so that you can think a bit more around what's going to be the practical steps around providing the necessary care, when this happens. The other thing, and I've got a minute left, and so you can read through my other comments, is just around your recruitment. So you say that you want to, that a lot of what's documented in the literature is in-hospital experiences, and that you're interested in what happens afterwards. So I wonder then, if you don't want to recruit via community samples, so why not on social media have a flyer that invites women
and that you mentioned specifically there women who have received care in public health. So does it have to go through these facilities, or can you recruit more broad? And if it is, I understand why you would want to go through these facilities so that you can think about what can practically happen next there. And if that's the case, fine. Don't, the compliance thing is good, but then include healthcare providers from these in how you're making sense. And the last thing is, if I may, the data analytics approach, I know it's under consideration. Remember, in that kind of phenomenology, you need to do careful bracketing around your experiences so that you get to the essence without any influence. That's very hard to do, especially with a topic like this. And progressive math analysis will give you actually the platform through which to interrogate your own reflections against those of the moms and actually bring that into how you write. So, and it's methodologically flexible and actually nice. And a deviation from what's in the literature, because I see they both did kind of the same thing. I think engage with the problem rather than try to practice. If I do that.
Would you like to respond? Thank you.
Thank you so much. That was the kind of the input I was hoping for. I really like the situation of feeding healthcare workers, and especially with service providing, and that is really one of the main motivations behind doing the work. Because what we've noticed is what we see the need of mothers are, and we've tried to implement and sport briefly. I used sample earlier this week, and we realized we see the gap and see that it's needed. Mums need support, but practically it didn't work because moms were saying, actually, I don't have time in my day to feeding and going down and doing this. So engaging with moms to know what is the practically offering in the service to make the lives better. And I think then talking to healthcare workers makes a lot of sense. So thank you for that suggestion. And also for the data analysis, and we will definitely keep looking into that a bit more and speak to my supervisor about it. Yeah.
Thank you so much, Marie. Do you have a question from the floor? Please, Madeleine.
I think it's just more of a clarity, just that the sample size you said 18 to 40. I'm just, age, sorry, 18 to 40 years old. I'm just thinking there might be a lot of discrepancies in 18-year-old bereaved mothers versus 40-year-old bereaved mother. I know that it's 6 months, so just something to consider. And then I think your focus groups, if that were to materialize, maybe look at a trained mental health professional to facilitate those focus group discussions, given the nature and sensitivity of what might come up in those.
Other than the researcher.
Yeah. So maybe the researcher should be either a lay counselor that's received adequate training, or even a registered counselor, or someone that has experience with mental health service.
Thank you so much, Megan. If you have any burning questions for Marie, you can catch it during the lunch break and speak to her about them. Thank you so much. Thank you, Marie. Well done. Next up, we have Ms. Tina Nissan, Professor as her supervisors of Professor Kenneth and Westhuizen and Dr. Danella Bernardo. Thank you.
Morning, everyone. All right, so for my presentation, I'm going to take you through exploring how to optimize National Suicide Prevention Hotline, and it's going to be a mixed methods analysis. Just to begin, I thought it would be nice for you to understand my why, which is a bit of my reflection, I guess, positionality. So I have an interest in suicide prevention. I do have an interest in youth population, but the presentation has since evolved to cover general population and an interest in mental health economics. I've had a background developing interventions, training packages, and I've also been a service provider. So to people who have had suicidal ideation, some who have died, and as recently as 2024, lost a friend by suicide. So we have the background. I think I'm fortunate to have at least 2 colleagues who presented on suicide. So the statistics should be fairly similar on a global perspective. It seemed to be the 3rd leading cause of mortality, especially amongst the youth 15 to 29. But the data that I saw from Kenya is different. They're seeing more of a burden in the older population. we are seeing that majority, nearly 75%, which is almost 2/3 of the suicides, actually happening in lower middle income countries like Kenya. Our standardized rate, our age standardized rate for suicide is 8.9 per 100,000 in the population, which means we are similar to the global average, although we are lower than the African average. The prevalence is also quite high on a global perspective, but we don't really have as detailed data for the African context, which is one of the gaps that I identified. So in light of this, I thought perhaps we know the risks in Kenya. We know what social determinants are associated with suicide ideation, suicidal behavior in suicide. We also know that there's a good national move towards suicide prevention. So this is evidence in our action plan. We have a suicide prevention strategy, and we're actually one of the countries that successfully decriminalized suicide in January 2024, and we are on the move towards repeal. So there's actually an action in there. And within our suicide prevention strategy, one of the aims is to actually increase access through establishing a hotline. But we still have the same, common problems in public mental health, which is inadequate mental health financing, and that financing is competing with other mental health priorities. And even more so, we don't have a very distinct ring-fenced budget for mental health prevention and promotion where suicide sits. So it has to compete with other prevention priorities. But now we also know that we have a demographic that has more access to mobile phones. In Kenya, we do quite well in terms of uptake across ages. So this is actually an opportunity to increase access at relatively lower cost. But even when they've determined what we should do in the form of suicide prevention through our strategy, there isn't a very clear direction on how to operationalize this, So how do we cater to the different vulnerabilities? So because of that, in my study, I want to explore how to optimize this and then also propose a costing framework so that if they were to implement, then they have an idea of what should go into it by way of cost. Not the actual costs, but just to inform the cost drivers. So my objectives will be three-part. One, I'll start by mapping out which suicide hotlines that we have in Kenya that provide suicide prevention services. Then now go and talk to service users, service providers, and managers, as well as technical experts on hotline use, just to get their insights. And then now from that, derive a costing framework. I will not discuss this in detail, but it's good for you to know that there is a theoretical framework that I'm working with, because it's what is going to inform how I structure the questions that I ask the people who I shall interview. So just keep that in mind to be relevant later. So in terms of methods, I will do a sequential mixed methods, and the setting will be Kenya, because this is more a national intervention, then it is not tied to a specific geographic location. But it's important for you to know that mental health has been decentralized to our counties, the 47 counties, but there are some functions that still sit in the national government. So there's a lot of this work, including the hotline, that would sit in the national government, which is centered in Nairobi. We have many ethnic languages, but our two national languages are English and Swahili. So these are some of the things when you're thinking of hotline services, just thinking of how do you operationalize that in a very ethnically diverse country. I will now take you through my study procedure, starting with objective 1, which is to map the national hotlines that are in Kenya. So the first step will be to do a desk review, just to identify what is available. Then snowball to key stakeholders to identify any additional organizations, contact them, and then thereafter now initiate data collection. So I intend to use Kobo with the questions that are relevant to the mapping mapped out onto Kobo and then collected. And for this, we thought we could either collect them during the KIIs or before. So this will really be informed by the amount of information we get at the point at which we begin interviewing participants. Then once we complete mapping, I think it's presumed that the data would fall into categories. These are not the concluded categories, but certain broad defined categories. So this is what would be downloaded, stored in a secure server, then begin cleaning, data cleaning on Microsoft Excel. Then I shall proceed to do analysis. So for this first stage, the data analysis will be quantitative, just looking at more caller demographics, caller patterns, human resource, and this would be more descriptive. So that's just a sample of perhaps how it would be visualized upon analysis. Then going into study objective 2, this is now where I talk to people, the users, the providers, service providers, and the experts. And I'm going to talk to 4 different categories of people. So I'll talk to people with lived experience, and then service providers will be hotline service providers, but also hotline service managers. So those fall within the same ecosystem. And then the technical experts will be from the technical working group for suicide, which is national and run by the national government. So I shall take you through what will be the eligibility process for this category. They will be, for service users specifically, I'll work with organizations that work with people with lived experience. We shall take people who are residing in Kenya, have self-reported to have suicidal ideation and not currently receiving any acute mental health service. There was earlier some discussion of how we would do the screening, so I would be keen to hear your insights on whether we should retain some sort of risk-based screening. I'll be keen to hear your perspective. Then we shall do consenting by providing information through the organization, orienting to the study, and walking them through informed consent. Keep in mind this entire process will take place after ethical approval, which I shall explain when talking about ethical considerations. So for my service providers and managers who work within the same context, they will actually be identified from the organizations that were marked in Objective 1. So initially, we will speak to the organization to identify prospective participants who will be linked to the researcher, that is myself. We shall provide information sheets, and those who are interested will be provided information on the study, so study orientation and consenting based on the following criteria. So they have to be currently working in that organization, have at least 6 months experience either providing for the service provider or managing or supervising services. And I recognize that the last one is a little bit of a duplication. Initially, it was tied to the population demographic, but that has since changed. For the working group members, we shall snowball, of course, through the national chair of the technical working group. We shall obtain, prospective contacts of who we can interview, initiate contact with them, provide them with information. And the people who will be considered are people who are active in the working group, have been in it for at least a year, because we meet quarterly, so a year would be favorable, and have experience on a national level delivering, suicide interventions or developing policies. And then those will be consented. So the collection for data here will be KIIs, so aiming for 8 to 16 participants, 2 to 4 per group. And the questions I shall ask them will be based on the CFIR domain. So the theoretical framework I mentioned is what will be used for the questions. We will go more for information depth or information power. I'm so sorry, Burmese. As opposed to data saturation, because we actually think we've identified the right participants to tell us what we need. The interviews will take maybe 1 to 1.5 hours with the possibility of it being 2 hours because of the mapping, and we'll use a hybrid approach, online or physical. Our data for analysis for this will be very qualitative and based on the framework analysis, but because we shall use the CFIR, we will use that to map into the categories. We will do verbatim transcription and do 2-person coding using the above steps for framework analysis. Finally, our objective 3, we will now develop a costing framework. So whatever we find from the participants, we'll identify key cost domains, then identify what costs drive those domains, and then now come up with a structured checklist. Of importance, we are not deriving any costs. These are my ethical considerations. Of course, I'll get approval from UCT in Kenya, and I'll get a research license. Everybody will provide informed consent. We'll ensure privacy and confidentiality through anonymization, secure storage. We will inform our participants on the risks and benefits, especially for the people with lived experience, and we'll have the option of referral. We'll have to refer, especially for the people with lived experience. Compensation will be in the form of participation in the study. So as I end my presentation, I just wanted to tell you a Swahili quote, which is called Usipoziba ufa utajenga ukuta. which if you translate into an English context means prevention. In a sense, prevention is better than cure. Don't fix the crack, fix the crack so that you don't have to rebuild the wall.
Thank you. Nieuwe is from Griekenland and Fatima.
Right, good morning, everybody. Good to see you again after the first meeting we had, I think, 3 weeks ago almost. Yeah. And great to hear everyone's progress with the proposals. So, Tina, thank you so much for your proposal. It was really very well written. It was very clear. The aims were well stated, and you were addressing a really critical public health issue around national suicide prevention in Kenya. It's got a potential to make a really big contribution to suicide prevention. But the methods were a good fit with the aims of the study. So my comments are really just for further improvement. What's really an excellent proposal. My first suggestion is around the CFIR, the Coordinated Framework for Implementation Research. In your proposal, you mentioned it quite briefly, and you mentioned the 5 levels, but I think we could have done more to maybe unpack those and then match them more clearly to the research objectives. You did it more in your PowerPoint presentation was in your written, so I think you really got it in hand. That was the one suggestion. I think with something like the CFIR, it's a very useful and very comprehensive framework. So being able to plug your research method. Then the second suggestion is around how you organize the information in your protocol. At times it was difficult to see which methods were matched to which objective. Here in the presentation again it was super clear, so I think you probably got it in hand. But there were times when I was reading some of the data collection methods, I wasn't sure which objective. Then for your second objective, which is to explore service user insights, provider and management, suicide prevention experts insights. I think it would strengthen your proposal just to get a clearer sense of how you go about identifying organizations that currently follow suicide prevention. I'm sure if there's a national database or a directory. You mentioned using a snowballing approach based on networks that you have. But I guess you want to reassure potential future reviewers of your study when you publish it further down the line that you've got a representative sample of organizations. So you can spell out how you go about that, and also how you would potentially identify service providers who are not so well. And then the last comment was really about your costing framework. So it's great that you've got Danetta. I think what would really help is if you could spell out the actual costing framework in a bit of detail. I know that you had some nice ideas for the structure, which you did here, but in the proposal that I read, I thought it could be spelled out. And especially, what are the different kinds of cost domains you would consider? What methods would you use to collect the costing data? Really spell that out. So, and I want to just conclude with a question, which is how would the costing framework be used? You would have it as a product of your research. How do you envisage it would be used by national suicide prevention compliance? Congratulations, really great.
Thank you. Would you like to take a moment to respond to your comments?
Sure. Thank you so much for that feedback. I think we were told from the beginning everything is iterative, so you make it better and better. So I agree. I'm still in the process of familiarizing with the theoretical framework. I'm very happy that my lead supervisor is somebody who's familiar with it and has used it. So I'm intending to use the first quarter to really just get a better sense of it and see how to better integrate it into my objectives and methods. I will explore with my supervisor how to clarify the how of which organizations, who to reach, so that it also is transparent and does not look like it has any level of bias. And I agree with the aspects of the costing framework. So this is also an area I'm still learning and trying to familiarize. So I will really rely on Jonella as part of the mentorship to understand this domain better.
Thank you so much.
Just to say, I've written also detailed comments in the editing protocol on that.
Thank you.
Wonderful. Thank you so much. Do we have a question from Phil? One, we'll take one. The photographer is also at the center. I'm hoping it's okay. You can grab Tina. Don't grab. During the lunch break. Thank you so much, Tina. Well done. Up next, we have Ms. Hewitt Ayo, a supervisor of Professor Claire Pallidesis and Dr. Stan Perry.
Hey, good morning, everyone. My name is Hewitt and I'm from Ethiopia. So, I guess my protocol title is on prevalence of mental health problem among leprosy patients who develop reaction, support cross-sectional study, and it will be conducted in a 5 leprosy hospital in Ethiopia, leprosy referral hospital. So as an introduction, what's leprosy? When we say the definition of leprosy is a chronic infection caused by a bacteria called Mycobacterium leprae. As you can see in the picture, these are the first sign and symptom of leprosy. When a person develops a leprosy, these signs will be showed. And there's also another complication called leprosy reaction. When we say leprosy reaction, it's a complication caused by an immune response produced against Mycobacterium leprae. So this means that every leprosy, it's not means that every leprosy patient develop a reaction, but some of the patients might develop the reaction because of the medication complication in the immune response. So as many studies reveal that 50% of leprosy patients they have a likelihood of developing disability because of the reaction. So what's the rationale of the study? Mental health problems are very common among leprosy patients, and the most common mental health problems occurred among these people are depression, anxiety, and stress. When we see studies, there are many studies revealed that the prevalence of mental health problems among leprosy patients, among common mental health problems occurred among these people. There are several studies that investigate this problem. However, when it comes to reaction patient, almost there is no any data or information regarding assessing the mental health problem of leprosy patient with reaction. So what's the aim of this study or my study? The aim of my study is to determine the prevalence of mental health problem among leprosy affected patients, those who develop a reaction, and also to identify some associated factors and contributing factors for their mental health problem. This study has 2 objectives. So the first objective is to assess overall prevalence of mental health by focusing specifically on depression, stress, and anxiety. And the patients will be those who are attending the 5 leprosy referral hospitals in Ethiopia. The second objective is to identify any association between socioeconomic, demographic information and other clinical data with mental health problems, specifically by focusing on depression, anxiety, and stress. So what are the methods that we are going to use? It's a quantitative study. Our research is a quantitative study, and it will use a cross-sectional study because since we are focusing on investigating prevalence and associated factors, we found that the cross-sectional design is the best fit for our study. When we see the study settings, as I said earlier, we will focus on the 5 leprosy referral hospitals across the country. So these hospitals are usually located in high burden leprosy areas. And since they are the only referral hospital, almost all of the reaction patients will be referred to this hospital to manage their reaction. So as a participant recruitment inclusion criteria, we have those persons that will be recruited to our study will be person affected by leprosy who developed a reaction and who started their clinical follow-up from September 2026 to February 27. That's a study period, and they should be 18 and above. And also their information, their personal information as well as their medical information has to be recorded in the registry book that's found in the leprosy clinic. As an exclusion criteria, we put like two exclusion criteria. The first one is those with cognitive and memory impairment will not be included in our study, and it's because they struggle to recall their past experiences regarding the experience that they had with depression or anxiety. So we exclude those people, and we also exclude those people with severe illness and severe pain, because those who develop reactions somehow sometimes pass through with a severe illness and pain. So we exclude those for the sake of their discomfort and comfort. When we come to the procedures, the first thing that we will do is secure an ethical approval, and we will secure ethical approval from the UCT as well as from the Alert Ahari Ethics Committee. Since we are Alert is a hospital that is one of our study sites, so they have their own ethics committee there. We will request an ethical approval from there, and the good thing is once we have this ethical approval from this hospital, we are good to go with the other 4. So we'll have ethics approval from this hospital. And the second thing that we will do is to request a formal permission for each hospital to go and interview the patients and review some clinical data. Once we are done with that, the next thing that we will do is to go to the leprosy clinic and review the registry book. We review the registry book, and this registry book is kind of standard. It all works in the 5 leprosy referral hospital. So we review that registry book and we develop a list of participants based on our inclusion criteria. So our list will have like an information like name of the patients, ID, age, and gender, and some clinical data like that we want to see in our study, like disability grade, type of reaction, and treatment duration, because all this study with all this variables will be included in our study to see any association with if they have any association with the mental health problem. On the sample, the first plan is to include all the reaction patients. As much as possible, we are planning to include all the reaction patients in our study. But if that's not possible, if the number of the patients are not manageable to be involved in our study, we already have a plan B. Our plan B is to randomly select a representative sample from almost the actual number of patients that visit the hospital. So once we are done with this, the participants will be approached when they come to the leprosy clinic for their regular health checkup, and they will be asked if they are interested to be a part of the study. And they will also be consented if they are willing to provide the information directly from themselves, as well as from if they are okay, if we can take their medical history. So all this process will be done by the healthcare professional workers in the clinic. The data collection will be done, as I said, by the healthcare professionals working in the leprosy clinic. And also the list that I was talking about previously will also be developed by the healthcare professionals, and they will get like an intensive training to do all this prior to the data collection process. So the data collectors, the clinical nurse, will be responsible in conducting the data collection by using the standardized mental health scale. They will be responsible to fill out that. They will also be responsible to the study questionnaire. We will have a separate study questionnaire that address some socio-demographic information and clinical data like disability grade, treatment duration, and reaction type, and the like. So the measure that we use is for depression, anxiety, stress scale. It's a screening tool. It's not a diagnostic tool. The reason why we use this task is it's been used in many researchers that's worked on leprosy and mental health. Moreover, this scale is also translated in one of the language spoken in our country, local language. It's also that the translated version is also validated in our context. So we will use this scale. We will also use assess stigma and social support, and we will use a standardized scale to assess this. As a data management, we will use like a rate cap to collect the data. The data will be set in the UCT and the Ahari server. SPSS will be used to analyze the data. descriptive analysis as statistical one. We use descriptive analysis so that we can make an association between some of the demographic information and the mental health. We will use a chi-square because we have categorical variables like reaction type, disability grade. So in order to associate those categorical variables with the mental health, we will use chi-square. And finally, we'll also plan to use a t-test and linear regression model for further analysis. So the ethical consideration, as I said before, we will secure ethical approval, and the participants will be provided with the information sheets and the consent form. We expect that the participant will encounter a small risk, that's the emotional disturbance when they are asked about their previous experience. But if they show something like serious psychological distress, they will be referred out to a psychiatric clinic. And this arrangement and the referral linkage will be done prior to the data collection. As a benefit, we consider that when the participants involved in this study, they will get an opportunity to provide input in the future leprosy clinical service improvement, confidentiality, all the information will be kept in a secure and safe place, and only the study team will have access to those information. And even the data collectors, the healthcare professionals, they are not allowed to discuss the information that they have collected either with the hospital administrator or with other colleagues. Finally, the finding of the study will be disseminated or communicated with the hospital administration and with some of the stakeholders working directly with leprosy. For example, like leprosy associations, we have leprosy associations in Ethiopia, so we will communicate the result of this finding with these stakeholders.
I'd like to invite firstly Professor Emily Garland to provide some comments. Thank you so much, Rich. It's very clear presentation, but also very clear well with the protocol. Really interesting study focusing on what's in the very vulnerable population, and I think under research population, and if your secondary degree has potential to gain understanding on the mental health needs of that vulnerable population. So I just have a few comments, some of which actually have been addressed in your presentation. So in your rationale, you provide a thorough explanation of leprosy and the complications of reactions here, particularly after studying the multi-drug therapy. And it would be good to provide an indication of the proportion of individuals who with leprosy who are taking this medication, and to get a sense of coverage, but also to gauge whether the study is conducted among patients which are representative of the leprosy population, or just among subgroups. So in your presentation, I actually say that 50% of the burden is linked to those reactions, but it's not clear in the protocol, so you just highlight that. And you mentioned that the 5 hospitals doing the study, and all the 5 hospitals available in the country, right? So it's not a subsample of the list. Okay, great. So just make sure that's clear in your protocol. And you didn't mention it here, but you talk about the exclusion criterion of impairments, cognitive or memory impairments. In your protocol, you mentioned age, so I just wanted to know whether you'll have like a specific cutoff for age, or how you'll actually assess impairments in that regard. In terms of the measures, I think your protocol could benefit from clarifying which information will be collected from the medical records exactly, and if participants haven't consented to accessing those records, so consented to the study but not to accessing the records, which data will be collected directly from the patients, and if there's going to be missing data, if you do so. And then in the case that healthcare professionals, the clinical nurses will be both recruiting and collecting the data. And I just wanted to know what the rationale was for this. And because that's likely going to lead to social desirability bias. So they might feel the pressure to actually accept part of the study if it's the nurses that you should give, provide care to them when you have the regular follow-up visits. And then also how you can mitigate that. So I understand the practical implications and why these might be the best people to actually collect data, but then how you're going to try and reduce the pressure and bias into that. And then finally, one more thing, you indicate that you're referring participants if they show distress. And given that you are using the DAS-21, I was wondering whether you consider using a cutoff on those 3 subscales for anxiety, depression, and stress, and whether, you know, if this, even if they don't display distress during the experience phase, if they screen above a certain cutoff, would you consider them for the brain?
Thank you very much for commenting.
Thank you for all the comments. That was very helpful. So regarding the age, you are right. We're discussing about this issue with my supervisor. And when I say age, I was assuming that the more people get older, the more they have the memory problems. So that's why I say old age, but we have discussed and decided that we have to make it more specific. That's why we have changed it into the memory impairments. So that's acceptable. Regarding the medical record, as I said previously, there are information, standardized information that has to be captured in the medical record. For example, the reaction type. When we say reaction, there are 2 types of reaction. So is it a type 1 reaction? Is it a type 2? This information is available on the registry book. The other information that's available in the registry book is a disability grade. Is it a 0 disability, or grade 1 disability, or a grade 2 disability? So all these information are available in the medical registry book. So since we want to explore and see if there's any association between this medical features and the mental health problem, we will explore this, capture this information from the registry book. Regarding the nurses, we prepared the nurses to do all the process because of the feasibility, because we want all the workers to be performed at the same time across all the hospital. But it's a good input, so we consider and discuss how we can manage the problem that will occur in relation to this. And the DAS, yes, we will use depression, anxiety, stress scale, and at first, I haven't considered that those who scored a higher score on this scale. Yeah, it's right. We should have a plan B or a backup so that this problem can be managed with the hospital, and something that we will consider during our.
Thank you so much. Do you have a question? Very interesting study. Thanks.
Thanks. Really, really interesting study. So I may have missed it, but I wanted to know more about your sample size. You know what your sample size would be. Not how would you go about deciding on your sample size, what parameters? And especially thinking, of course, you've got 5 hospitals, so you extract 5 random sampling.
Yes. So our plan is that we are planning to do a minor assessment of the data collection. The first plan is as much as possible to include all the reaction patients that are taking their treatment in each hospital. But if that's not possible, if the number of the patients available at that study period is not manageable, we're planning to calculate the sample, take sample from the total patients, from the actual number of patients who are taking their medication in each hospital. So each hospital will have a different sample size based on their actual number of patients using the service. That's our plan.
Yes, it's actually quite clear your protocol is that this calculation will be conducted at that point if needed.
Yeah.
And I suppose that will be based on your sort of previous literature on the prevalence of depression anxiety and stress.
A question, yes.
Does Ethiopia currently have any laws against personal information? Personal and mental information. So in South Africa, we have the Copy Act. So we also access records without the permission of the participants. I think this was, but just I don't think you get that. So it would be perfectly acceptable for you then to make a list of persons from the files.
We only need to get a permission from the hospital administration. Yes, once we get their approval, we can accept the medical records.
Yeah.
And yes, and just to be more safe, that's why we want the healthcare professionals to do the list to capture all those information from the medical records so that we can go directly and access everyone's medical record. But once we're done with the developing the list, we will also approach the participants and we will inform them that we are going to use some of their clinical data for our study. So we consent them. Yes. Yes.
Yeah. And then also then from there, from the Ministry of Health, you would also have an application to them yes, the works study.
Only from the hospital.
Only from the hospital.
Yes.
And then
as long as we have the approval,
yeah,
we can directly go to the hospital and get their permission.
Okay. And also requirements that it doesn't interfere with their day-to-day work.
Yeah, that could be one. That could be one problem, but we are planning also to compensate the healthcare professionals because we are asking them to do additional tasks other than their routine health workers. So this will be something that we will discuss with the team and the hospital administration on how to manage.
Yeah.
Yeah.
Yeah. Thank you so much. You did a good job. Thank you. Next up, we're doing so good for time. Next up, we have Dr. Premier Zerede, and his supervisor is Professor Emily Gar.
Thank you so much. My brother from Malawi ended up with a morning brain panel. I end up with lunchtime. So I will step up and feel free to do so. Yeah. So thank you very much. So my study is about integrating mental health into primary health care settings to improve the detection of mental health conditions. So it's a study of the mental health for all program that is done in Cascade, Burkina Faso, and I've been supervised by Prof. Emil. So what inspired our study? So the rationale first is the facts. From WHO, there is a mental health treatment gap. Why? Because 17% of the health of the years lived with disability are actually attributable to mental health conditions. Globally, there is a service coverage gap. We, for example, up to 71% of people with psychosis not receiving health services. So in response, WHO, so in response, WHO came up with the mental health gap action program, aiming at integrating mental health care into family health care settings. That have been adapted and adopted in Burkina Faso since 2014 with a program which has been rolling out since then. And the phase 3 that's now ongoing in Cascade region, Burkina Faso. But despite those implementations, we notice a lack of investment in mental health research in general and in detection in particular, with only 5% of mental health research towards detection and diagnosis. So one can ask the question, what is the program impact on detection in Burkina Faso and the Cascade? And also, what are the healthcare providers' perceptions of mental health? So many questions, but we will focus on answering one research question. So our aim is to actually assess and explore how the MHGAP training and implementation impacted detection in the Cascade region and how the MHGAP is perceived by the different healthcare providers at different levels of care. So our objective will then be to assess the change in detection, to explore the perception of healthcare providers' role in detecting priority mental health condition, to explore healthcare providers' reflection on barriers and facilitators of the mental health for all program implementation in the Cascade region. So which method are we going to use? In the coming slide, we will describe our study design settings, then the quantitative part and the qualitative parts. This is only done for the presentation and it's not the chronology of our study. In terms of the design, we are using like I said, a quantitative design using the program phase 3 monitoring, evaluation, and health report data. As for the qualitative, we are using key informant interview with healthcare staff at all levels of care. What is our study setting? We will do our research in the Cascade region of Burkina Faso, which is a rural area with one regional hospital, three regional hospital, district general hospital, 8 medical centers, and 110 primary health care settings. It's a mainly rural area for a population of 800 plus thousand people. So for the MME data, they are being collected quarterly since then by the Health District, the Health Regional Directorate, and CPM Global since January 1st, 2024, up to December 21st, 2025. So we will measure, so that gives us 9 time points, and we will measure the number of healthcare settings having at least one professional trained on MHGAP, the number of social workers trained on MHGAP, the number of consultation, and number of people consulted in healthcare settings, all during outreaches, and the number of new cases with priority mental health conditions. So how we'll proceed, after approval from my line manager, and to extract, we will extract data from January 1st, 2024, that's a pre-training actually, to December 31st, 2025. Clearance from health authorities will be thought to get data collected from the regional and the primary healthcare settings. For the analysis, we will use the extract data for descriptive analysis and presenting data over time with graphs disaggregated by health facilities and primary healthcare and priority health conditions. So we also compare detection across districts using inference statistics, but that needs the test need to be discussed with our supervisor. So for the key informant interview, we will purposely sample regional hospital, each district general hospital, and each primary healthcare setting in each district. So, and that will allow us to select 2 psychiatric nurses, 1 medical doctor, and 3, like 1 nurse, 1 midwife, 1 community health workers in 1 to 3 primary healthcare settings, with a total of 13 participants. So we'll include health workers who have been trained on MHGAP as master trainer or a service provider and have worked in that facility for at least 6 months. And we will exclude any who is not willing to sign the consent form. So for the recruitment, potential participants will be identified through the training list. Then a research assistant will contact them first time to discuss the study scope, objective, and assess their eligibility, and also discussing confidentiality issues. So, and also about the mitigation strategy of those issues. And if the participant is willing, they will be sent the research information sheets and the consent form via WhatsApp. And secondly, for the second time, they will be contacted 1 week later around to sort the approval for the in-person interview. So the research assistant will then bring hard copies of the consent form to be signed for starting the interview. So those will be 45 minutes semi-structured interview to gather information on detection, change, primary healthcare, perceived change in detection, change in their roles, barriers, and facilitators. And the first 2 interviews will serve as pilot interview, and the topic guide may be amended. So the audio recording will be transcribed and translated from French to English. The interview will be conducted in French, obviously. And we will carry out a thematic analysis, both analytic and interpretative. So we are doing so because the principal researcher could dive in his knowledge on the program and to guide the interviews and interpret the transcription with his background, because I've been involved since the design of the program up to February 2024. So he has been in contact with master trainers, but he has not been in contact with the primary healthcare workers. So some participants of this study. So in terms of ethical consideration, we will seek University of Cape Town Health Research Ethics Committee and also our National Ethics Committee, if necessary. This is still under discussion. And of course, with the relevant health authorities at Congo from Burkina Faso to get the participant consent and safeguard their rights. All research documents will be translated into French. Okay, into French, yeah, and at all contacts with the participant, they will be reminded of their rights to withdraw, to opt out at any time without any prejudice. We are also seeking to give a small compensation to provide for transportation if need be. We have some risk in our research is low, but still we anticipate a psychological discomfort and also a quite a concern about confidentiality, because there have not been so many people trained in that region, so they may be identifiable. So even though we'll take all measures to identify all the transcript, the names, and etc., there's still that need that risk that needs to be mitigated. So all the data will be stored in a server of UCT, ensuring the name are not identifiable, ensuring any information slightly tangentially related to them or their location are being deleted. And also we'll do member checking after transcription and check if they are still okay with what we have in our transcript. Our study could contribute to a better tailoring of mental health integration in primary health care and also setting in the Cascade region, in Burkina Faso broadly, and of course a strengthened system that may benefit the participants themselves. Thank you very much for your attention.
When you were interrupted and another something you commented to the house.
Thanks for that. Thanks for that. Heaven there's that I'm on camera with. All right. Now, Donella says, thank you very much for sharing the protocol. It's a very strong, well-developed study. And she says, congratulations on getting here. The policy relevance is clear, the contextual grounding is solid, and the mixed methods design is appropriate. So she's giving you some reflections. She says your justification is strong and well articulated. She talks about how well you've dealt with situating your study in the global literature. She did say that you want to be clear the study is framed as addressing an implementation and program learning gap, rather than aiming to demonstrate causal impacts of training or the program. So she said the objectives are well aligned and feasible. Again, she says objective 1, very important to be explicit that the quantitative component does not aim to estimate causal impacts. The analysis relies on routinely collected M&E and health records data without a pre-intervention baseline and without a comparison region. And you also cannot she said, without the ability to disaggregate results like cadre or other characteristics. Okay, objectives 2 and 3 are appropriate and complementary. She said, try and make that distinction more clear in the protocol, the distinction between the two objectives. While they address different aspects of implementation, it's not always explicit how they differ in terms of focus, questioning, and analysis. She did like your approach to qualitative sampling strategy and allows insights into different points in the service delivery chain and referral pathways. she said it would be useful to explicitly state the same group of participants are contributing to the both qualitative objectives and just provide clarity on how these shared interviews are used to address different objectives. And okay. Going down to the analysis, she said the protocol states reflexive thematic analysis will be used. You've got a strong awareness of positionality, which she really appreciated, and the strategies we propose to mitigate social desirability bias and manage reflexivity are thoughtful. She said maybe think about something that a clear articulation of what conceptually guides the qualitative component, maybe using implementation science concepts or frameworks. She did also mention CFIR, which Tina alluded to earlier. She's saying it's not a requirement, but it might help you organize your interview questions. And she said the integration of mixed methods for design is really strong. And she says it's a very solid, thoughtfully designed protocol with a clear contribution. Well done.
Thank you so much.
All right. Okay. All right. Thank you. Thank you very much to my supervisor. Yes, for the framework, actually, that's maybe the first time even my supervisor we've heard this. I come across that, but to be honest, I didn't have a grasp on it. So I didn't mention it on my protocol. Yeah, and so now it's actually an invitation for me to dive into it and liaise with Tina, yeah, to understand that and use it. So I think majority of the of what Prof just read is recommendation and comments, yeah, and I will definitely incorporate that and still engage my supervisor to actually have the protocol straightened. Yes. Maybe we just take the opportunity to greet my family. They are online. Yeah. So they know my wife, my mother. They know all the the trouble that I've been to be here. And thank you for the opportunity of being here. It's my second application. Yeah.
Do you have a moment for a question or something?
Yes.
Thanks so much. Really, really interesting proposal, and it's considered really, really policy relevant. I had a question about how you would track your 9 time points. Whether it's possible to do some kind of inferential analysis. So there's something called interrupted time series analysis, where you look at the trend before an event and the trend after an event. For example, you can look at the trends in detection of mental health conditions in clinics in the points up to the introduction of the image gap training, and you can see whether there's a change in that trend over time. I don't know if you have enough time points, but that might be something to explore.
Thank you so much. Thank you so much for your contribution. I will definitely discuss that with my supervisor. Yeah. Maybe she's here.
Yeah. Maybe you can add that there are 3 time points before the start of the training. So that's what we're looking at doing.
Yeah, fascinating study. I and yourself and Emily are both French, so that's quite nice for the interviews. Why do you want to translate it to English? So I see you translating all the consent forms into French, and it's usually done in French. Do you need to translate everything into English, or maybe just for the publication purposes, have bits of the English quotes? Because that's quite expensive unless it's so is it necessary? Even if you do submit it in the publication and the transcripts are in French, if you analyze it that way, and only it's up to somebody else then if it's open source to want to translate it if necessary. But I mean, just because yeah, because it is French, so you.
Wow. Okay.
Very expensive.
Yeah. Thanks very much. Actually, we have a discussion that is still ongoing about ethics. That's a bit tricky because we are francophone. Yeah, and we may need, if we are okay. So the thing is that it's the Ministry of Health that is approving health research, health-related research. But in terms of the program that have been implemented, they can't provide that approval without having an ethical approval. So that's, yeah, I have, but we need to have that before actually saying that we don't need ethical approval. So if we do need ethical approval, like on the national ethical approval, we need to translate everything, and it is costly and time consuming because it's only one entity that's approving all this. So it's actually a good point if it's not necessary.
No. Of course it's necessary, but I'm saying everything's going to be in French. Of course it has to be in French because the interviews will be in French.
Yeah.
Do you need to then worry about translating the transcripts back into the English afterwards if the analysis is going to be done by a French speaking? So yes, you need all your edits.
Yeah.
But yeah, just something.
All right. Yeah.
The late stage experience.
Thank you.
Thank you so much, Dr. Zerebe. Our final MPhil presentation for 2026 be done by Ms. Yandiso Martinez, and her supervisor is Prof. Fano Rateli, who has self-like timing, who came just in time to support her. You have 10 minutes. She's been waiting all day.
My name is Yandiso Martinez, and
I don't think they hear you.
yeah, listen now.
What do you do?
Okay, my name is Yandiso Martinez, and I will be presenting my thesis topic, and it is perceptions, behaviors, and mental health of male perpetrators of gender-based violence. And my supervisor is Professor Sophanora Tebe at Stellenbosch University. So, as we know, gender-based violence has increasingly become a local and a global health crisis, with 1 in 3 women reporting sexual and or physical abuse globally. And men commonly remain at the center of these attacks as perpetrators. So gender stereotypes and patriarchal norms have been seen as the promoters of violence that is meted against women. So although these factors have been researched, there remains a gap in understanding men's mental health and the perception of themselves and the victims before and during the acts of gender-based violence, so the perpetration. The aim of the study is to explore how convicted male perpetrators perceive themselves, their victims, and the experiences of gender-based violence. And the objectives would be to explore how convicted male perpetrators of gender-based violence construct their sense of self in relation to the violent acts, to understand how they describe and perceive their victims in the context of gender-based violence, and to also explore how perpetrators connect their past psychological and emotional experiences to the current perceptions and behaviors within that context. So just to put out there that the aim and the objectives are still being reviewed between me and my students. Okay. So the study will employ a qualitative methodology using phenomenological approach, and the correct reporting guidelines will be used to ensure the transparency of the research and the write-up of the paper. My setting
So my participants will be recruited at Oldsmore Maximum Security Prison, which houses over 7,000 inmates. And the facility has 5 demarcated divisions. So medium A houses juvenile inmates between 14 and 17. Medium B houses same-sex male adults only. Medium C houses male inmates who are day parolees and those who are people released. And then we have a remand or detention facility and also a female facility where juvenile inmates and those who are adults are housed. And the reason for selecting this setting is that subjects are accessible, although they will not be coerced to take part. So a minimum of 6 to 8 participants will be recruited for the study, and the inclusion criteria are they will identify as men, 18 years and above, and will be incarcerated for committing a gender-based violence crime, specifically a rape homicide offense. Exclusion criteria is individuals who do not identify as male, juvenile offenders, so below the age of 18, and those who are incarcerated for other offences other than gender-based violence situation and non-rape homicide. Okay, so participant sampling. Participant sampling will be used to recruit participants for the study, and this is because participants will be the ones who have the desired characteristics required for the research, and Baltimore has quite a diverse demographic. So there are inmates from varied ethnic groups, cultural groups, and of course, GBD is not unique to a specific group. And for that reason, the study will include male from the different groups, and the recruitment process will continue until saturation point. Okay. So the recruitment process. The initiation of the study requires the involvement of many different people at different levels. So first step would be to gain ethical approval from Stellenbosch University's Research Ethics Committee and also the Department of Correctional Services Research Directorate. Following approval, the researcher will liaise with the relevant officials and gatekeepers at the prison to facilitate the recruitment process. And this will be done by identifying the facility, identifying the inmates or the desired participants from the correctional center inmate database. And we will always keep in mind the inclusion and the exclusion criteria for this selection. And thereafter, the researcher and the relevant gatekeepers will then arrange an initial meeting to explain what the study is about with the selected participants who meet the criteria. So it will be a brief meeting where I just tell them what the study is about, and we will talk about the ethical considerations of the study. The participants will then be given time to ponder on their willingness to take part of the study, and those who have indicated their interest by way of verbal consent will then be asked to provide specific details to the research team. And on my second visit, I will then arrange to meet with the participants individually, where we will then go through the research study information letter in depth, so it will also be using form as well. And then the participants will be given time to ask questions, really give them clarifications, and we will then also go through and sign the informed consent, and this will then constitute the beginning of the data collection and interview process. Thereafter, times will be arranged with the gatekeepers to start the interview process with the participants. And this will be done in a private room, secluded yet guarded, to ensure privacy, anonymity, and confidentiality of all information.
study procedure. So the first interview, the researcher will then meet with the participants first and re-explain the process of confidentiality and the right for them to opt out should they no longer want to be part of the study. Languages, the interviews will be conducted in isiXhosa and English by the researcher, and then there will also be a field worker who will do interviews in Afrikaans, who will have a background as a counselor with the HPCA. Interviews will last for an hour to an hour and a half, and all audio recordings and field notes will be used to capture the data. The second interview will then take place because of the descriptive nature of the study. It will take place after 3 to 4 weeks of the first interview, and within that time, the researcher will then listen and review the data and search for gaps and areas needing clarification. And thereafter, she will then work on adding questions that need clarity just for in-depth information. The interview schedule will consist of open-ended, semi-structured interviews, and the schedule will be role-played, piloted with a peer prior to data collection, as well as with the clarifying questions for the interview as well. Okay. Data analysis of data will be transcribed solely by the researcher. All data will be coded with the participant's pseudonym, so no identifying information on any data information, and access TI will be used to code the data. Coding and all transcribed data will be translated by the researcher and also by the field worker who will undergo training on how to do all of this. As with the same interviews, we will undergo training. And then we will also do intercoder checks just to ensure that there isn't any researcher bias. And we will also use the reflexive thematic analysis framework. So trustworthiness has a couple of umbrellas, and the researcher will be mindful to always be reflexive of herself in this process, especially being a female in a hyper-masculine environment. And also my background as a counselor and how that could maybe change my interpretation of the narratives. And also in any counseling institute pop up, I will definitely put them aside just to ensure that the space is ethically sensitive. I'll also keep a journal to note down any feelings and thoughts of the process, and also I'll continue my own personal mental health journey. And I've also listed the 4 pillars that I will go through in this process. Ethical considerations. So for the data safety, no information that could identify the participants will be on the paper, and safekeeping of all information will be communicated with the recipient, as I explained earlier, and all transcripts will be converted from Word to PDF just to guard against any accidental or intentional omissions or additions of any information, and all data will be deleted once transcripts have been checked. Potential risk discomfort. There might be some reluctance on part of the participants, just because of how inherently coercive the prison setting is. They might feel coerced or forced to take part. They might be reluctant to share information because of fear of the judge, stigmatized, or also maybe they might be afraid to share information because maybe they might think it might be shared with guards or prison inmates. Procedures for distressed participants. So there will be an SOP put in place for instances where there is any emotional distress. The researcher will contain the situation initially by pausing the interview and allowing the participant to express their emotions and themselves in that way that they feel they need to. Thereafter, arrangements will be made with the on-site support prison mental health staff for further support after the interview. And also they'll be reminded of the choice to withdraw from when they need to. Okay. So there's no direct benefits for participation, but it will shed light on psychosocial
practices that impact gender violence. Okay, so I think so. Let's start with it. The informed consent process. Okay, I think I've mentioned that before, that recruitment in prisons now will work, and they will not be coerced to partake in any interviews. And then reimbursements, there will not be any monetary reimbursements for taking part of the study. And the option to provide refreshments will be explored with the relevant officials at the prison. So that's it.
So much effort put into this presentation. It's very clear. And also to say that your proposal, this was much clearer than the proposal. So I think my comments are now really useless. So, start there. So the first thing is, you mentioned in your background, more broadly in your background, then when you go into the actual detail of your population, you're actually saying specifically very homeless. The background is a little bit disconnected. Then I went a bit of a rabbit hole and found some studies that looked at the specific pieces. We found one together the other day. I think you found one and showed me. There's 4 other ones that are very similar, also been in the same prison, which I found really interesting. Then I started reading those, and there's so much really good information about how they access the prison, all the challenges they face accessing the prison. It'll almost help you navigate their mistakes and make it a bit easier for you. Really fascinating. This one study had about 5 pages of just the gatekeeping issues. So it really is going to be a bit of a challenge for you, but I think you could use other researchers to navigate it. Yeah, so definitely have to bring that into your background. And also because one of the studies was so similar to yours, you really got to make sure that your gap is really similar in so many different ways. So it's really about maybe modifying your aims objectives a little bit more to fit that public mental health focus. It's a public mental health course. Your methods, you described your setting really clearly. I like that you had all the reflexivity, and you mentioned it here about your positionality, about being a woman going into a prison. So I'd like to see a little bit more about that, because that dynamic, it's going to change what you're hearing. I was a bit like, oh, you're very brave. But what will those, we're talking about gender-based violence, but also gender dynamics and so forth. Obviously something to discuss with your supervisor. I really liked your stage recruitment process, how you had the consent process almost on its own. It will help with that coercion in a way. So if someone just doesn't want to come back to the next piece, it'll be very clear. So I quite like that you're giving them, it's not like you're doing consent and then doing the interview. You're kind of giving them a bit more time, which was great. I mentioned the prison. I did like the 2 interviews as well, because often when people say they use phenomenology, they'll do a 45-minute interview. I think I've said this before to many of you. They do a 45-minute interview and suddenly you must know all their lived experiences. We know that that's not always the case, or shouldn't be the case. So I do like your 2 pieces. Wasn't quite sure what you would be asking in them, but I think it's because your aims and objectives maybe are going to play around a little bit. So I'm not going to go into it, but something to be very clear on. What will you be doing in that second interview? They're great that you're having it. You added software in your proposal here, which was great, but it wasn't the other piece. Yeah, and all the ethical issues that I had mentioned, but there are so many in the papers that I had read that you're definitely going to need to apply for your ethical considerations. There's quite a few key pieces of working with prison inmates. There's even kind of a policy from the prison themselves that I've put through in terms of what you could apply for ethics. I think that just means you can make this even stronger, which I think is really great. That's all.
Thank you so much. Question 2. Catherine mentioned the issue of the sensitivity of being a woman doing the interviews. What about thinking about a man doing the second one? To then look at, so the person doing the second one would have to have read the transcript and discuss it, but to maybe different things coming out, and maybe an aspect for the analysis as well. Do you want to respond to that, please? Thank you so much. Do you want to think about it? We'll supervise them.
I'm just suggesting, given the fact that you go in as a woman to do the interviews, and the rate was categorized around it being quite a sensitive issue. When you being a woman may raise issues in the interview, but my suggestion is why not get a man to do the second interview, and discuss with you what gaps there are. But that second interview might come up with all sorts of things that never came up because in the first interview. I don't know, it's just a thought.
Yes.
Okay, I can definitely discuss that with my supervisor, but then I think in terms of comfortability, will they be comfortable speaking to a different person who's not me or the good work that they've seen the person?
Yeah, it would have to be part of the consenting process. Yes. So that they know that that's going to
Another question, yes, come on. On excluding friends, I was wondering if someone specifically made that request to say, I'm not that comfortable being interviewed by female, you exclude those people or say there is going to be consideration for that. And my second question was whether the second interview would also be an obligation enrollment in one person might say, no, I'm actually only talk to you once, but not for the second time. And then what would you do with that they will still use it for? You need them as big to speak how we and so
Thank you so much. Amazing. It's such an interesting study. I can't really do the results, but I just wanted to find out why only 6 to 8 participants.
6 to 8 participants, it could be more, but so I was thinking, and I was discussing with the professors in the that we will do screening until saturation. So depending on how many offenders are listed as having committed a rape, homicide offense, that will then, I think, inform the number of participants as well. So it could be more offenders.
Any other questions? Congratulations to everybody. I want to mention specifically everybody who did amazingly well, and we can just give them a hand around the floor. Just want to mention that both Lumbi and Yantis were graduates of our PG DIP program, so we are very proud of them. Thank you, everybody, for this unit.
Thanks, Claudia. Yeah, so as Claudia said, and I think as a few people have said, well done to everybody. You've really blown us away. It's been a fascinating week. So congratulations on reaching this important point in your MPhil program. So it's been a pleasure supporting you in these first 3 weeks, and all your hard work and all the peer psychosocial support that happened. It's really all paid off. And I also want to thank every supervisor and lecturer and every staff member that's helped us and been part of this 3-week lecture block. I want to thank all of you who attended online and in person. It's been really great to have friends and family, and members of the deanery and international colleagues and so many different people, friends who've joined us online. So it's been great to have